Welcome everyone to another chapter of Advanced Pathophysiology. Today we're talking about chapter 29, the alterations of erythrocytes, platelets, and the hemostatic function. As always, my pages may not always line up with yours, but we'll be reading it in its entirety. So without much further ado, we'll jump right in. Alterations of erythrocyte function involve either insufficient or excessive numbers of red blood cells in the circulation or normal numbers of cells with abnormal components. Anemias occur when there are an adequate number of red blood cells or an insufficient volume or mass of red blood cells in the blood, while polycythemias develop when the number or the volume of red blood cells is excessive or high. Each of these conditions has many causes and is a pathophysiologic manifestation of a variety of diseases or disease states. The primary role of clotting or homeostasis is to stop bleeding through an interaction among vascular endothelium, platelets, and the clotting system. Many disease states are associated with clinically significant aberrations in any of the three necessary components of clotting. So this chapter will discuss alterations of platelets and various components of clotting and their control systems. So we'll jump right in with anemia. Anemia is a reduction in the total circulating red cell mass, or a decrease in the quality or quantity of hemoglobin. Anemias commonly result in either blood loss, impaired erythrocyte production, and increased erythrocyte destruction, or a combination of all of those factors above. Total circulating red blood cell mass is reflected by changes in plasma volume caused by either dehydration and fluid retention. An example of this is decreased plasma volume from dehydration, with a normal red blood cell mass may indicate a relative polycythemia or an abnormally elevated red cell count because of the hemoconcentration. Severe dehydration can correlate with increased hematocrit and hemoglobin levels. Fluid retention is associated with hemodilution rather than a true decrease in red blood cell mass. So we have classifications and general characteristics. There are several ways to classify anemias. A useful way is by underlying main mechanisms. Another way to classify anemias is based on the changes that affect the erythrocyte size or hemoglobin content. The terminology reflects these characteristics. The terms that end in "cytic" refer to cell size, whereas chromic refers to the hemoglobin content. Microcytic, hypochromic anemias are caused by disorders of hemoglobin synthesis, particularly iron deficiency. Macrocytic anemias arise commonly from abnormalities that hinder the maturation of erythroid precursors in the bone marrow. Various etiologies occur in the normocytic normochromic anemias, and the specific shape of the red blood cell can help determine the cause. Additional descriptors of erythrocytes associated with some anemias include the Anisocytosis, which just means assuming various sizes, or poikilocytosis, assuming various shapes. So this following table here is a good spot to hit pause, because you'll be able to read over all the classifications of anemia according to their underlying mechanism. And as always, I'll try to stop where it makes most sense to hit pause. Test. So here we're taking a look at different appearances of red blood cells in various disorders. So It's a good spot to hit pause, and you can kind of look at all the different types of disorders and how they would look like microscopically. An easy one might be L, your sickle cell anemia. So, the main physiologic manifestation of anemia is a reduced oxygen carrying capacity of the blood, resulting in tissue hypoxia. Symptoms of anemia vary depending on the body's ability to compensate for reduced oxygen carrying capacities. Anemia that is mild and develops gradually is usually easier to compensate and may cause problems for the individual only during physical exertion. As the reduction in the number of red blood cells continues, symptoms become more pronounced, and alterations of specific organs and the compensatory effects become more apparent. Compensation generally involves the cardiovascular, respiratory, and hematologic system. So here is a good spot to pause so you can kind of review how the body compensates in terms of a low red blood cell count. And then, unfortunately, here's one of the few charts where it looks like portions of it slightly cut off. Here you see the lab findings for various anemias. And unfortunately, the very last section, I think it's aplastic anemias, is semi-cut. A reduction in the number of blood cells in the blood causes a reduction in the consistency and volume of blood. Compensation for a reduced blood volume causes interstitial fluid to move into the intravascular space, expanding plasma volume. This movement maintains adequate blood volume, but the viscosity or thickness of the blood decreases. The diluted blood flows faster and more turbulently than normal blood, causing a hyperdynamic circulatory state. This kind of hyperdynamic state creates cardiovascular changes, increased stroke volume, and heart rates. These changes may lead to cardiac dilation and heart valve insufficiency if the underlying anemic condition is not corrected. Hypoxemia, a reduced oxygen level in the blood, further contributes to cardiovascular dysfunction by causing dilation of the arterioles, the capillaries, and venules, thus leading to decreased vascular resistance and increased flow. The increased peripheral blood flow and accelerated venous return further contributes to an increased heart rate and stroke volume in a continuing effort to try to meet that normal oxygen demand and prevent cardiopulmonary congestion. These kinds of compensatory mechanisms will eventually lead to heart failure. Tissue hypoxia creates additional demands and compensatory actions on the pulmonary and hematologic system. The rate and depth of breathing increases in an attempt to increase the availability of oxygen. These kinds of demands are accompanied by an increase in the release of oxygen from hemoglobin. All these compensatory mechanisms may cause individuals to experience a shortness of breath, or dyspnea, and a rapid pounding heartbeat, dizziness, fatigue. In mild chronic conditions, these symptoms might be present only when the demand for oxygen is increased, so again, during like physical exertion. But in severe conditions, they may be experienced even at rest. Manifestations of anemia may be observed in other parts of the body: the skin, the mucous membranes, the lips, the nail beds, the conjunctiva. They all might become pale as a result of reduced hemoglobin concentration. If anemia is caused by red blood cell destruction or hemolysis, the skin may become yellowish because of the accumulation of the products of hemolysis. Tissue hypoxia of the skin results in impaired healing, as well as the loss of elasticity. In addition, there's also the thinning and early graying of the hair. Nervous system manifestations can occur if the anemia is caused by a vitamin B12 deficiency. Myelin degeneration may occur, causing a loss of nerve fibers in the spinal cord and producing paresthesias, or that numbness, gait disturbances, extreme weakness, spasticity, and reflex abnormalities. Decreased oxygen supply to the GI tract often produces abdominal pain, nausea, vomiting, and anorexia. A low-grade fever of less than 38.5 occurs in some anemic individuals and may result from the release of leukocyte pyrogens from ischemic tissue. When the anemia is severe or acute in onset, the initial compensatory mechanism is peripheral blood vessel constriction, diverting blood flow to vital organs. However, that decreased blood flow detected by the kidneys activates the renal renin-angiotensin response, causing salt and water retention in an attempt to increase blood volume. These situations are emergencies and require immediate intervention to correct the underlying problem that caused the acute loss of blood. Therefore, long-term compensatory mechanisms do not develop. Therapeutic interventions for slowly developed anemic conditions require treatment of the underlying disorder and the palliation of associated symptoms. Therapies include provision of transfusions, corrected um, via dietary imbalances, and administration of supplemental vitamins and iron. So, effective management of an individual's blood is described in this "What's New" category here. So, if you would like to pause, you're more than welcome to read this section on patient-centered blood management. Bringing us to anemias of blood, acute blood loss. Your post-hemorrhagic anemia is a normocytic normochromic anemia caused by acute blood loss. Acute blood loss is mainly a loss of intravascular volume, and the effects depend on the rate of the hemorrhage that can lead to the cardiovascular collapse, shock, and potential death. A major cause of acute blood loss is usually trauma. Severe trauma is a rising global problem. Traumatic injury results in an annual worldwide death of more than 5.8 million people, or about 1 in 10 mortalities. Uncontrolled post-traumatic bleeding is the leading cause of potentially preventable death among injured individuals. The pathophysiologic mechanisms associated with a traumatic injury is an evolving field of study. So, this following table in 29.3 presents classifications of estimated blood loss for about an average 70-kilogram man based on initial presentation, as developed by the American College of Surgeons Advanced Trauma Life Support. The overall reliability and validity of the ATLS classification is still an ongoing study. However, if you'd like to pause here, you'll be able to see the classification of estimated blood loss and how they go about it in that sense. And then there is another spot for you to pause here for another What's New, this one regarding traumatic injury, bleeding, and coagulopathy. So I'll slow down for sections for you to pause, and you're welcome to read those aspects, as well as the appropriate chart on traumatic coagulopathy. These are good spots to pause, mostly because I know there's a lot of charts and a lot of sections that I sort of skip over, and I don't skip over them because I don't believe they're not important. It's just otherwise these little lessons become 6 to 8 hours long. So, volume loss reduces mean systemic filling pressure, resulting in decreased venous return. The initial manifestations are caused by cardiovascular adaptations to blood volume depletion. Indexes to predict the risk of hemorrhagic shock are proposed as useful to provide prompt and appropriate treatment. If the acute blood loss is not severe, complete recovery is possible. Within 24 hours of blood loss, lost plasma is replaced by mobilizing water and electrolytes from tissues and interstitial spaces into the vascular system. The hemodilution that results lowers the hematocrit value concurrently. There is often a rapid elevation of circulating neutrophils and platelets. Neutrophils can rise to levels between 10,000 and 30,000 within a few hours as a result of a shift of marginated leukocytes into the circulation and a release of leukocytes from the bone marrow. The platelet count can rise to levels of about 1 million. In severe blood loss, more immature cells, your myelocytes, and nucleated red blood cells may enter the circulation. Reduction in tissue oxygenation stimulates production of erythropoietin and increases the production of erythrocytes in the bone marrow. Iron recovery from destroyed erythrocytes may occur if the acute blood loss is internal. However, if blood is lost externally, iron stores may be depleted, and erythropoiesis may be impeded. Hemorrhage that is chronic produces adaptations that are less prominent, but the individual may experience an iron deficiency anemia. When iron reserves become depleted, initial treatment for the acute blood loss is restored, or is a restoration of blood volume via intravenous administration of saline, dextran, albumin, and plasma. Large volume losses may require transfusion of simple, fresh, whole blood. That's our packed red blood cells. Successful therapy is first indicated by the return of erythrocytes to their normal size and shape. As the bone marrow begins to produce more erythrocytes, an increase in the number of reticulocytes is seen. Changes in the appearance of erythrocytes associated with reticulocytosis may give the impression that the underlying hemolytic process is occurring. A normal erythrocyte count is usually noted in the 4 to 6 weeks, but hemoglobin restoration can take up to 6 to 8 weeks. That brings us to chronic blood loss. Anemia from chronic blood loss only occurs if the loss is greater than the replacement capacity of the bone marrow. If iron stores are depleted, iron deficiency anemia would occur. Anemias of diminished erythropoiesis. The anemias of diminished red cell production are heterogeneous and can be classified according to the underlying mechanism. The most common anemias of diminished red blood cell production are the result of ineffective erythrocyte DNA synthesis, commonly caused by nutritional deficiencies of either vitamin B12 or folate. Coenzymes that are required for nuclear maturation and DNA synthesis. These anemias are called macrocytic or megaloblastic anemias and are characterized by their abnormally large erythroid precursors or megaloblasts in the marrow that mature into large erythrocytes. The following box here lists the various causes of megaloblastic anemia. Other anemias from underproduction of red cells are secondary usually to renal failure and or chronic inflammation. So a good spot to pause so you can see the different causes of megaloblastic anemias, whether it's from the vitamin B deficiency, impaired absorption or decreased intake, your folic acid deficiencies, or when there's an increase in requirement, impaired utilization or unresponsiveness to vitamin B or folic acid therapy. So, megaloblastic anemias. With megaloblastic anemias, the cells are changed and challenged to make DNA. However, RNA production proceeds normally. The cells have slow maturing nuclei but have normal maturing cytoplasm. Therefore, megaloblastic erythroid precursors grow large before the larger nuclei become mature enough to signal division. Examination shows the nucleus to be more immature than the cytoplasm, hence the term nuclear cytoplasmic asynchrony. The overall nuclear cytoplasmic asynchrony from the ineffective DNA synthesis produces megaloblastic changes in the bone marrow with resulting anemia. These defective erythrocytes die prematurely, called erythropoiesis, which decreases their number in the circulation and causes anemia. Damaged erythrocytes undergo cell shrinkage, membrane changes, and rearrangement of plasma membrane, phospholipid distribution with efflux of phosphatidylserine. Macrophages have receptors that recognize the surface of PS and remove the damaged erythrocytes from their circulation. Dietary cause of vitamin B12 deficiency is decreased intake. Vitamin B12, known as cobalamin, is dependent on dietary vitamin B12 intake. Plants and vegetables contain a little cobalamin, and strictly vegetarian and macrobiotic diets do not provide adequate amounts. Another important cause that results in megaloblastic anemia is pernicious anemia, caused by an autoimmune destruction of parietal cells that make the intrinsic factor. Intrinsic factor, or IF, is a protein transporter necessary for the absorption of vitamin B12 in the intestines. The prevalence of folate deficiency has decreased because of food fortification with folate. However, it does occur among poor, elderly, and alcoholics, especially in countries without folate fortification. Vitamin B12 deficiency also can result from a malabsorption, or increased cell turnover and increased demand. Abnormal asynchronous maturation may affect the neutrophil series. Neutrophil precursors create giant metalomyelocytes with a tendency to have more nuclear lobes than the normal type. The reason for this transformation, however, is unknown. Other cells throughout the body also may demonstrate enlargement and nuclear abnormalities. Which brings us to pernicious anemia, also known as PA. Pernicious anemia is a type of megaloblastic anemia and is caused by a vitamin B12 deficiency, which is often associated with the end stage of type A chronic atrophy gastritis. Autoimmune gastritis impairs the production of IF, which is required for vitamin B12 uptake from the gut. Pernicious means highly injurious or destructive, and reflects the fact that this condition was once considered fatal. It most commonly affects individuals older than age 30 who are of the Northern European descent. However, it has been now recognized in all populations and ethnic groups. So here you're taking a look at the bone marrow aspirate from an individual who has pernicious anemia. So what is the pathophysiology? The principal disorder in pernicious anemia is an absence of the intrinsic factor. The intrinsic factor is secreted by gastric parietal cells and complexes with dietary vitamin B12 in the small intestine. That B12 intrinsic factor complex binds to cell surface receptors in the ileum and is transported across the intestinal mucosa. Deficiency in that intrinsic factor secretion may be congenital. However, it is often considered an autoimmune process directed against gastric parietal cells. Congenital IF deficiency is a genetic disorder that demonstrates an autosomal recessive inheritance pattern. The autoimmune form of the disease may have a genetic component, but no genetic pattern of transmission has been identified. Pernicious anemia is also frequently a component of autoimmune polyendocrinopathy, which is a cluster of autoimmune disorders or diseases of the endocrine organs, meaning your type 1 diabetes mellitus, your Addison's disease, your primary hypoparathyroidism, Graves' disease, and myasthenia gravis. All of these can frequently present as comorbidities. Autoimmune thyroiditis and a type of 1 diabetes, in particular, is associated with pernicious anemia. Other causes include surgical removal of the stomach, the resection of the ileum, and infestation with tapeworms. In addition, various conditions related to increased demand for a vitamin B12, such as pregnancy, hyperthyroidism, chronic infection, and disseminated cancers, are associated with pernicious anemia. Environmental conditions also may contribute to chronic gastritis. These include excessive alcohol or hot tea ingestion, as well as smoking. Drugs known as proton pump inhibitors, or PPIs, are used to decrease gastric acidity, but also may decrease cobalamin absorption, although it is not believed that they actually cause pernicious anemia. Although pernicious anemia is a benign disorder, individuals with type A chronic gastritis also are at risk for developing gastric adenocarcinomas and gastric carcinoid type 1. The incidence of carcinoma in these individuals is actually between 2 and 3%. The presence of pernicious anemia with autoimmune gastritis leads to gastric atrophy from destruction of parietal and thymogenic cells. Again, individuals with PA commonly have autoantibodies against the gastric hydrogen potassium ATPase, which is the major protein constituent of parietal cell membranes. Early in the disease process, the gastric submucosa becomes infiltrated with inflammatory cells, including the autoreactive T cells. It appears that the T cells response initiates gastric mucosal injury and triggers the formation of the autoantibodies. The susceptibility to develop pernicious anemia, therefore, is linked to genetic variants involving the inflammasome, which suggests a relationship to innate immunity. Eventually, the parietal and thymogenic cells are destroyed and replaced by mucus-containing cells. Gastric mucosal atrophy, in which gastric parietal cells are destroyed, results in the deficiency of all secretions of the stomach, the hydrochloric acid, pepsin, and IF. Initiation of the autoimmune process may also be secondary due to the past infection of a Helicobacter pylori or H. pylori. Although active infection of H. pylori is considered rare in individuals with pernicious anemia, more than half of these individuals possess circulating antibodies against the microorganism, suggesting that there is a history of infection. The current opinion is that in genetically prone individuals, antigens expressed by H. pylori mimic the parietal cells of the hydrogen potassium ATPase, resulting in the production of an antibody that binds and damages the parietal cells. So, what kind of clinical manifestations do you see in pernicious anemia? Well, PA develops slowly, possibly over 20 to 30 years. So, 60 years of age is the median age of time during the diagnosis. Because of the slow onset of symptoms, PA is usually severe by the time the individual finally decides to seek treatment. Early symptoms are often ignored because they are nonspecific and vague and just include your passive infections, your mood swings, and gastrointestinal, cardiac, and kidney ailments. When the hemoglobin finally does decrease significantly enough, the individual experiences the classic symptoms of anemia: weakness, fatigue, paresthesias of the feet and fingers, difficulty walking, loss of appetite, abdominal pain, weight loss, and a sore tongue that is smooth and beefy red, secondary to that atrophic glossitis. The skin may become lemon yellow as a result of a combination of pallor and icterus. Hepatomegaly, indicating a right-sided heart failure, may present in the elderly, along with the splenomegaly, which is non-palpable. Neurologic manifestations result from a nerve demyelination, that may produce neuronal death. The posterior and lateral columns of the spinal cord also may be affected, causing a loss of precision and vibration sense. Ataxia and spasticity. The cerebrum also may be involved with manifestations of affective disorders, most commonly of the depressive types. Low levels of vitamin B12 have been associated with neurocognitive disorders. Overall, the consequences of a vitamin B12 deficiency can include encephalopathy, myelopathy, and peripheral and optic neuropathy. An increased prevalence of serum vitamin B12 deficiency has been reported among individuals with Alzheimer's disease. Individuals with atrophy and metaplasia of the gastric mucosa associated with pernicious anemia have an increased risk of gastric cancer. So, what's our evaluation and treatment, therefore? Should be pretty straightforward. Diagnosis of PA is based on clinical manifestations and a variety of test results, including blood tests, bone marrow aspiration, serologic studies, and gastric biopsy. The following tests are used to diagnose pernicious anemia: severe to moderate megaloblastic anemias, leukopenia with a hypersegmented granulocytes, low levels of serum vitamin B12, elevated serum levels of homocysteine and methylmalonic acid, and an outpouring of reticulocytes and an increase in hematocrit level, usually after about 5 days of parenteral administration of vitamin B12. The presence of circulating antibodies against parietal cells and intrinsic factors also useful in your diagnosis. Gastric biopsy usually would reveal a total achlorohydra, which is diagnostic for pernicious anemia because it occurs only in the presence of a gastric lesion. So, what we would want to do is replacement of vitamin B12, cobalamin, and that is the treatment of choice. Initial injections of vitamin B12 are administered weekly until the deficiency is corrected, followed by monthly injections for the remainder of the individual's life. The effectiveness of cobalamin replacement therapy is determined by the rising reticulocyte count. Conventional wisdom and practice assumed that oral preparations were ineffective because there was no IF to facilitate the absorption of vitamin B12. However, recent experience has shown that higher doses of orally administered vitamin B12 are absorbed across the small bowel and are beneficial. So you can do initial oral treatment as well. Again, untreated pernicious anemia is still considered fatal, usually because of heart failure. Death occurs after a course of remission and exacerbations lasting anywhere from 1 to 3 years. Since 1926, when replacement therapy began, mortality has been reduced significantly. Today, death from PA is considered rare, and any relapse that occurs are usually the result of a non-compliance with your therapy. So, that brings us to a folate deficiency anemia. Folate deficiency anemia, a deficiency of folic acid, results in the megaloblastic anemia having the same pathologic consequences as those caused by vitamin B12 deficiency. Folate is an essential vitamin for RNA and DNA synthesis within the maturing erythrocyte. Folates are coenzymes required for the synthesis of both thymine and purines and the conversion of the homocysteine to methionine. Deficient production of thymine in particular affects cells undergoing rapid division. Humans are totally dependent on folate dietary intake to meet the daily requirement of the 50 to 200 micrograms per day. Increased amounts are required for pregnant and lactating females. Absorption of folate occurs primarily in the upper small intestine and does not depend on the presence of any other facilitating factor, such as IF. After absorption, folate circulates through the liver where it is stored. A folate deficiency is more common than a vitamin B12 deficiency, particularly in alcoholics and, and, and in individuals with chronic malnutrition or malnourishment. Alcohol interferes with folate metabolism in the liver, causing a profound depletion of folate stores. Fat diets and diets low in vegetables also may cause folate deficiency because of the absence of plant resources of folate. It is estimated that about 10% of North Americans have a type of folate deficiency, although the incidence has been on a decline in the US since the fortification of foods with folate and the increased use of folate supplements. The box in 29.1 lists the various causes of folic acid deficiency, including the common decreased intake, increased requirement, and the impaired utilization. So, it's pathophysiology, therefore. Impaired DNA synthesis secondary to folate deficiency results in megaloblastic cells with clumped nuclear chromatin. Anemia may result from apoptosis of erythroblasts in the late stages of erythropoiesis. In addition to anemia, folate deficiency in pregnant women is associated with a neural tube defect of the fetus. Folate is necessary for the reduction of circulating levels of homocysteine, a risk factor for development of atherosclerosis. Thus, folate deficiency increases the risk for developing coronary artery disease. A deficiency of folate also is implicated in the development of cancers, specifically colorectal cancer. So, what clinical manifestations do we see? Clinical manifestations are similar to the cachectic, malnourished appearance of individuals with pernicious anemia. Specific symptoms include severe cheilosis, which are your scales and fissures of the lips, and painful ulceration of the buccal mucosa and tongue, characteristics of burning mouth syndrome. Burning mouth syndrome may be a secondary issue to a large number of disorders. The mechanism underlying folate deficiency as a cause remains unknown, yet GI symptoms may be present and include dysphagia, flatulence, and watery diarrhea, as well as a histologic and genographic changes of the GI tract, suggestive of sprue. Undiagnosed inflammatory bowel disease may be the underlying cause of a folate malabsorption in some individuals. And folate deficiency may suppress the proliferation of the intestinal mucosa, leading to the exacerbation of gastrointestinal damage. Neurologic manifestations, such as those that occur in pernicious anemia, are generally not seen in folate deficiency anemias. Any kind of neurologic symptoms are usually caused by a thiamine deficiency, which often accompany folate deficiencies. So, our evaluation of a folate deficiency is based on the measurement of serum folate levels and documentation of symptoms. Treatment requires daily oral administration of folate preparations until the adequate blood levels are obtained and clinical symptoms are reduced or eliminated. 1 milligram daily is sufficient for most individuals, although persons with alcoholism may require up to 5 milligrams a day. Prophylactic doses of 0.1 to 0.4 milligrams per day are sometimes given during pregnancy. Parenteral administration of folic acid generally is not used except in situations in which an individual has been using drugs that inhibit the dihydrofolate reductase. The administration of folate, the manifestations of anemia, should disappear within 1 to 2 weeks. After the folate deficiency has been corrected, long-term treatment with folate is not usually necessary if the appropriate dietary adjustments can be made to, maintain an adequate intake. An intake of folate, even as low as 400 micrograms a day, is recommended as a measure to reduce the risk of heart disease and stroke. The symptoms of vitamin B12 deficiency also respond to folate therapy. However, it is essential to exclude vitamin B12 deficiency as the cause of anemia because folate does not prevent the neurologic deficits found with a vitamin B12 deficiency. Which brings us to the microcytic hypochromic anemias. The microcytic hypochronic anemias, again, are characterized by the abnormally small erythrocytes that contain unusually reduced amounts of hemoglobin. The most common nutritional disorder of a microcytic hypochromic anemia is iron deficiency anemia, and is discussed here as well as in other chapters. So, iron deficiency. Iron deficiency anemia, or IDA, is the most common type of nutritional disorder worldwide, occurring in both developing and developed countries and affecting as many as 1/5 of the overall world's population. The prevalence of IDA is higher in developing countries, but IDA is common in the United States, particularly in toddlers, adolescent girls, and women of childbearing age. Populations also at risk for IDA include individuals living in poverty, infants consuming cow's milk, which has a poor bioavailability of iron, older individuals ingesting restricted diets, and teenagers eating poor junk food diets. The daily requirement of iron is about 7 to 10 milligrams for the adult man and 7 to 20 milligrams for the adult woman. The bioavailability of iron is especially important because only about 10 to 15% of the ingested iron is actually absorbed. Men typically ingest more iron than women, and premenopausal women, particularly during pregnancy, have an increased requirement. Increased requirement is an important cause of an iron deficiency in growing infants, children, and adolescents. The causes of IDA include dietary deficiency, impaired absorption, increased requirement, and chronic blood loss. Impaired absorption can occur in food disorders involving alterations of fat absorption and chronic diarrhea. Other causes for both genders include the use of medications that could cause GI bleeding, so your aspirins, your NSAIDs. Surgical procedures that decrease stomach acidity, intestinal transit time, and absorption, and eating disorders, such as pica, which is the craving and eating of non-nutritious substances, such as dirt, chalk, and paper. The clinical manifestations are mostly related to the reduction in adequate levels of hemoglobin. Females have a higher incidence of hypoferrinemia than do males, as well as IDA. The incidence peaks in females during the reproductive years and decreases after menopause. Those at highest risk are Black females living in urban poverty. Males have a higher incidence during childhood and adolescence, with a decrease occurring during young adulthood and an increase during late adulthood. An increased prevalence of iron deficiency has been observed in overweight children, adolescents, women, and those undergoing bariatric surgery. In developed countries, pregnancy and the continuous loss of blood are the commonmost causes of IDA. A blood loss of 2 to 4 ml per day is enough to cause IDA. Menorrhagia causes primary IDA in females. Males may experience bleeding as a result of ulcers, hiatal hernias, esophageal varices, cirrhosis, hemorrhoids, ulcerative colitis, or cancer. An occult bleeding source, such as a gastrointestinal cancer or other lesions, can lead to IDA. The astute clinician who understands the cause of IDA, maybe a cancerous lesion can save a life. Children in developing countries often are affected by chronic parasite infestations that result in intestinal blood and iron loss that outpaces dietary intake. Treatment of helminth infections result in the improvement in the anemia as well as in the appetite and growth. H. pylori infections also often found to cause IDA of unknown origin, although H. pylori impairs iron uptake. Iron deficiency anemia is associated with an increased absorption of other elements, such as lead and cadmium. Heavy exposure to both lead and cadmium causes a hypochromic microcytic anemia. Treatment of the iron deficiency is associated with the decrease in lead levels. Deficiencies in vitamin C, B1, and B6 may enhance sensitivity towards cadmium and lead toxicity. So, it's pathophysiology, therefore. IDA is a hypochromic microcytic anemia. Anemia occurs when iron stores are depleted. With inadequate dietary intake or excess blood loss, there is no intrinsic dysfunction in iron metabolism. However, both conditions deplete iron stores and reduce the hemoglobin synthesis. With metabolic or functional iron deficiency, various metabolic disorders lead to either insufficient iron delivery to bone marrow or impaired iron use within the marrow. Paradoxically, iron stores may be sufficient but delivery is inadequate to maintain heme synthesis, thus producing a functional or relative iron deficiency. Iron in the form of hemoglobin is in constant demand by the body. Iron is recyclable. Therefore, the body maintains a balance between iron that is contained in hemoglobin and iron that is in storage and available for future hemoglobin synthesis. Blood loss disrupts the balance by creating a need for more iron, thus depleting the iron stores more rapidly to replace the iron lost from bleeding. Iron also contributes to immune function by regulating immune effector mechanisms, your nitric oxide, your interferon gamma, and your T cell proliferation and cytokine activity. Acquired hypoferritemia may be part of the body's response to infection. Anemia can be part of the nonspecific acute phase response to any type of inflammation of sufficient degree. Many pathogens require iron for its survival. Thus, hypoferritemia would hamper their growth. However, the precise benefits or detriments of iron deficiency and immunity are still controversial. IDA occurs when the demand for iron exceeds the supply and develops slowly through three overlapping stages. In stage 1, the body's iron stores are depleted. Erythropoiesis proceeds normally, with the hemoglobin content of erythrocytes remaining normal. Then in stage 2, iron transportation to bone marrow is diminished, resulting in iron-deficient erythropoiesis. Finally, in stage 3, begins when the small hemoglobin-deficient cells enter the circulation to replace the normally aged erythrocytes that have been removed from the circulation. The manifestations of IDA appear in stage 3, when there is a depletion in the iron stores and the diminished hemoglobin production. So, clinical manifestations. Symptoms of IDA begin gradually, and individuals usually do not seek medical attention until that hemoglobin level begins to decrease to about 7 or 8. Your early symptoms are nonspecific and just could include fatigue, weakness, shortness of breath, and being pale around the earlobes, palms, and conjunctiva. So here you are looking at a couple manifestations of iron deficiency anemia. So as these conditions progress and become more severe, structural and functional changes occur in the epithelial tissue. The fingernails become brittle, thin, coarsely rigid, and spoon-shaped, or concave, as a result of impaired capillary circulation. Your IDA also is associated with unexplained burning mouth syndrome, as was discussed with the folate deficiency. Your tongue papillae atrophy and cause soreness along the redness and burning. The degree of pain experienced is directly associated with the amount of iron deficiency, and these changes can be reversed, usually within 1 to 2 weeks, of iron replacement therapy. Individuals also experience dryness and soreness in the epithelium at the corners of the mouth, known as angular stomatitis. Difficulty in swallowing is associated with the esophageal web, a thin, concentric, smooth extension of the normal esophageal tissue, consisting of mucosa and submucosa at this juncture between the hypopharynx and the esophagus. The duration of iron deficiency required for web formation is uncertain. Dysphagia also is exacerbated by the hyposalivation. The pathophysiology associated with these epithelial lesions is not well understood, but the lesions have the potential to become cancerous. Your non-heme iron is a component of many enzymes in the body, particularly those involved in the metabolism of amine neurotransmitters, the reduction of nucleotides, and the biosynthesis of methionine. Abnormalities and deficiencies of iron-dependent enzymes may account for many of the clinical manifestations of IDA. Individuals with IDA also exhibit gastritis, neuromuscular changes, irritability, headaches, numbness, tingling, and vasomotor disturbances. Gait disturbances are usually rare. The pathogenesis of neurologic symptoms is unknown, but may be caused by hypoxia in already compromised cerebral vessels. In the elderly, mental confusion, your memory loss, and disorientation are often associated with anemia and may be wrongly perceived as normal events related to aging. Iron deficiency in children is associated with numerous adverse health-related manifestations, especially cognitive impairment, which may be long-lasting and irreversible. Teenagers with a history of iron deficiency as infants are likely to score lower on cognitive and motor tests, even if the iron deficiency was identified and treated during infancy. So, its evaluation and treatment, therefore. Initial evaluation is based on the clinical symptoms and decreased levels of hemoglobin and hematocrit. Anemia appears only when iron stores are depleted and is accompanied by lower than normal serum iron, ferritin, and transferrin saturation levels. Your laboratory findings for IDA are included in Table 29.2. Iron stores may be measured directly by bone marrow biopsy and iron staining, or indirectly by laboratory tests for serum ferritin levels, transferrin saturation, or total iron binding capacity. Serum ferritin is a widely accepted and available measurement of iron status that has been used for the past 25 years. 1 microgram per liter serum ferritin corresponds to 8 to 10 milligrams or 120 micrograms of storage iron per kilogram in the body weight. A limitation on interpretation of the serum ferritin levels is that values may be elevated independently of iron status during acute or chronic inflammation, malignancies, liver disease, and alcoholism. A sensitive indicator of heme synthesis is the amount of free erythrocyte protoporphyrin within erythrocytes, a test that determines the concentration of soluble fragments. Transferrin receptor differentiates primarily IDA from IDA that is associated with a chronic disease. An indicator of iron levels is the level of serum transferrin receptor. Transferrin receptors are membrane glycoproteins that bind circulating transferrin for transport into cells. Soluble forms of the receptor are found in serum. The ratio of serum levels of transferrin receptor to ferritin estimates body iron stores and differentiates your primary IDA from anemia, secondary to chronic disease. A major drawback, however, is the lack of proper standardization for this STFR assay. The first step in treatment of IDA is to identify and eliminate sources of blood loss. With ongoing bleeding and replacement therapy is likely to be ineffective. Iron replacement therapy is required and very effective. Initial doses are 150 to 200 milligrams per day. Hematocrit levels should improve within 1 to 2 months of therapy. However, the serum ferritin level is a more precise measurement of improvement in total body stores of iron. Once the serum ferritin level reaches 50 micrograms per liter, adequate replacement of the iron has occurred. A rapid decrease in fatigue, lethargy, and other associated symptoms is generally seen within the first month of therapy. Replacement therapy usually continues for 6 to 12 months after the bleeding has stopped, but may continue for as long as 24 months. Your menstruating females may need daily oral iron replacement therapy until menopause. Your parenteral iron replacement is used in instances of uncontrolled blood loss, intolerance to oral iron, intestinal malabsorption, or poor adherence to oral therapy. Iron dextran has been the only parenteral agent available in the US. Intramuscular injection is the recommended method. However, intravenous administration is generally preferred because of the ability to administer larger doses. A significant concern in the use of IV dextran is the potential for severe anaphylactic reaction. Delayed allergic reactions are also major concerns. Medications that have recently been approved for parenteral therapy and treating IDA are sodium ferric gluconate complex in sucrose, as well as an iron sucrose injection. Iron dextran is recommended as the first choice in spite of its higher rate of adverse reactions. For individuals who are intolerant of iron dextran, the two newer agents are safe and effective alternatives. Drawbacks to their use include the higher cost and the need for multiple infusions, which brings us to anemia of chronic diseases. Anemia of chronic diseases, or ACD, is a mild to moderate anemia resulting from the decreased erythropoiesis and impaired iron utilization in individuals with conditions of chronic systemic disease or inflammation. Your ACD is a common type of anemia in hospitalized individuals. Table 29.4 lists the possible causes of ACD. This form of anemia also is commonly noted in the presence of cognitive heart failure. The anemia develops after 1 to 2 months of disease activity. The initial severity is related to that of the underlying disorder, but although persistent, it usually does not progress. Individuals may be asymptomatic, or the anemia may be coincidental clinical finding. ACD shares features observed in individuals with chronic obstructive pulmonary disease, in individuals with critical illnesses, after acute events such as a major surgery, severe trauma, a myocardial infection, and sepsis, and in the elderly. It shares some features with anemia noted in multiple myeloma and malignant lymphoma. So here's this table of underlying causes of ACD. ACD is one of the most common conditions encountered in medicine and is probably only secondary to IDA in the overall incidence. In individuals older than the age of 65, anemia is present in 10% of those who live in the community and in more than 50% of those who reside in nursing homes, with two-thirds of the cases being ACD or unexplained anemia. The elderly may be predisposed to ACD related to age-associated hematopoietic restriction and generally have increased concentrations of inflammatory cytokines, which again play a significant role in the development of ACD. The elderly who present with characteristics of ACD without an underlying malignancy or inflammatory condition are described as having primary defective iron utilization syndrome. So, what is the pathophysiology? ACD results from the combination of a decreased erythrocyte lifespan, suppressed production of erythropoietin, ineffective bone marrow erythroid progenitor response to erythropoietin, and altered iron metabolism and iron sequestration in macrophages. During a chronic inflammation, a large variety of cytokines are released by lymphocytes, macrophages, and the affected tissues. These include tumor necrosing factor alpha, your IFN gamma, interleukin 1b or beta, your interleukin 3 and 6. Impaired iron metabolism is partially the result of iron sequestration. Interleukin 6, in particular, affects hepatocytes and increases the release of the peptide hepcidin, which regulates the activity of ferroportin. Ferroportin is the primary transporter for the export of iron from macrophages to the plasma, and increased levels of hepcidin result in decreased ferroportin activity and suppression of the iron release. So here you're taking a look at the digestion of iron sources from food. So the pathophysiology of anemia of chronic disease. Erythrocyte destruction is the result of erythropoiesis. Most of the disease responsible for ACD damage erythrocytes, resulting in an increased efflux of plasma membrane phosphatidylserine and susceptibility to removal by macrophages. Your normal iron transport by transferrin also may be decreased as a result of competitive iron binding by inflammation-related increases in the levels of circulating lactoferrin and Apoferritin. Lactoferrin is a member of the transferrin family of non-heme iron-binding glycoproteins and under normal conditions is present in the blood in only small amounts. During inflammation, neutrophils release lactoferrin to bind iron and reduce its availability for bacteria. However, the affinity of iron for lactoferrin is 260 times greater than that for transferrin. Lactoferrin-bound iron is removed by the mononuclear phagocyte system and converted into ferritin, the storage form of iron. Apoferritin also has a higher affinity for iron and affects available iron in a similar manner. The erythropoietic defect in ACD is failure to increase erythropoiesis in response to decreased number of erythrocytes. In part, decreased erythropoiesis results from diminished production of erythropoietin by the kidneys. The kidney is frequently affected by chronic inflammatory processes caused by circulating immune complexes and other factors that deposit in the kidney and activate secondary inflammatory mechanisms. In addition, The failure in erythropoiesis may reflect decreased responsiveness of erythroid progenitors to erythropoietin. Decreased availability of iron would diminish the rate of erythropoiesis. Proliferation of erythroid cells is also inhibited by pro-inflammatory cytokines, especially your tumor necrosing factor alpha, your IFN gamma, and interleukin 1 beta. Your tumor necrosing factor alpha also directly induces apoptosis of erythroid progenitors, thus diminishing the number of responsive cells. In individuals who had anemia secondary to rheumatoid arthritis, the bone marrow contained elevated levels of interleukin-3, which correlated with the diminished expression of integrins on the surface of the cells of the erythroid series. Loss of integrins may prevent adequate interaction with stromal cells and matrix proteins, and inhibit erythropoiesis. Anemia associated with chronic renal failure may result from a variety of simultaneous mechanisms. Damage to the kidneys affects the secretion of erythropoietin, a necessary hormone for production of erythrocytes in the bone marrow, thus resulting in diminished bone marrow erythropoiesis. Uremic toxins that increase the blood secondarily to renal failure may suppress bone marrow function and damaged erythrocytes, which undergo erythropoiesis. Platelet function also may be defective in these individuals, which results in chronic bleeding and the loss of erythrocytes. Anemia may arise from the direct activation of the bacterial toxins. So, for example, your Clostridium perfringens produces an alpha toxin. This toxin has an enzymatic activity that disrupts the membranes of the cells. If the cells are erythrocytes, hemolysis will result. So, clinical manifestations. The anemia of ACD is usually in the mild to moderate range, with few additional complications. If the hemoglobin level drops significantly, clinical manifestations of IDA will appear. So, our evaluation and treatment, therefore, morphologically, ACD is initially normocytic normochromic, but as the condition persists, it becomes more hypochromic and microcytic. ACD is characterized by abnormal iron metabolism with low levels of circulating iron and reduced levels of transferrin. The most significant finding of ACD is the very high total body iron storage, although inadequate iron is released from the bone marrow for erythropoiesis. Very often the first indication of ACD is a failure to respond to conventional iron replacement therapy. Levels of erythropoietin are generally lower than expected for the degree of anemia. The affected individual also frequently present with low or normal total iron binding capacity, normal or high serum ferritin levels, and low concentrations of soluble transferrin receptors. Occasionally, it may be difficult to differentiate ACD from IDA. However, measurement of STFR may be useful. Levels of the STFR do not respond to iron supplementation in ACD, but they do so in IDA. Use of erythropoietin in treatment of ACD associated with arthritis, malignancies, and acquired immunodeficiency syndromes, so your AIDS, has met with limited success. Individuals with severe anemia secondary to chronic kidney disease can be treated successfully with erythropoietin and treatments to increase iron stores. However, the optimal degree of restoration of hemoglobin levels has not been determined, so the achievement of normal level increases the risk of hypertension, stroke, and potential death. Transfusion of the critically ill Individual may worsen the outcome and increases morbidity and mortality. The principal treatment is alleviation of the underlying disorder. Individuals who have ACD but demonstrate no evidence of inflammatory or infectious conditions are screened for the presence of malignancies. Which brings us to our aplastic anemia. Aplastic anemia, or AA, is a hematopoietic failure, or bone marrow aplasia, characterized by the reduction in the effective production of mature cells by the bone marrow, which are causing peripheral pancytopenia, which is a reduction or absence of all three blood cell types. Although the pathogenesis is not clearly defined, mechanisms include immune-mediated destruction of hematopoietic stem cells and their progenitors at various stages of differentiation. So here you're taking a look at aplastic anemias. The known causes of aplastic anemia are the chemicals and drugs, physical agents, or unpredictable exposures. Aplastic anemias can be inherited or idiosyncratic. The incidence of AA is relatively rare. The incidence in developing countries is somewhat higher and may be related to the greater exposure to certain chemicals known to cause AA. The incidence is bimodal, with one peak occurring between 15 and 25 years of age and a second peak occurring in individuals older than the age of 60. Your aplastic anemia is equally distributed between genders. So, here we're taking a look at the major causes. So, again, it's a good spot to hit pause so you can review them. Aplastic anemia are the most common types of bone marrow aplasia, with idiopathic AA accounting for approximately 75% of all confirmed cases, and being an autoimmune disease. Your secondary aplastic anemia, which accounts for about 15% of cases, is caused by a variety of known chemical agents and ionizing radiation. Chemical agents and drugs effects are included in the following table. The development of aplastic anemia with the use of these agents is generally dose-related, and the effects can be controlled with diminished dosages. In other instances, however, AA might develop after the use of a small amount of these drugs, with the anemia following a severe, rapid, irreversible progression. Your liver disease is also recognized as a cause of AA. So here's a table that shows the secondary effects. Try to go somewhat slowly here so that you can see them all. Again, if I'm ever going too fast, just hit pause. AA is constitutional or familial in origin, or is associated with one or more somatic abnormalities in roughly 5 to 10% of affected individuals. A subset of these is found to have defective telomerase RNA, resulting in shortening telomerase. This abnormality also is found in some individuals with idiopathic AA. Total body irradiation also causes AA, and in certain instances may be used therapeutically for this effect. Infections are also known to cause AA, with viruses being the most common agent. These include infections with HIV, Epstein-Barr, hepatitis, persistent parvovirus B19 infection also has been identified as producing bone marrow failure, resulting in AA. Parvovirus B19 has been identified as a cause of aplastic crisis in children who have sickle cell hemoglobinopathies and hereditary spherocytosis. Another condition associated with AA is the pure red cell aplasia, in which only the erythrocytes are affected. PRCA is a rare disorder and has been associated with autoimmune, viral, and neoplastic disorders, infiltrative disorders of the bone marrow, renal failure, hepatitis, mononucleosis, and systemic lupus erythematosus. It also is a well-recognized but infrequent complication of allogenic bone marrow transplantation, particularly when there is donor-recipient ABO mismatch. A thymoma often is found in association with PRCA and is also present in Diamond-Blackfan syndrome, a congenital disorder. A very small percentage of cases are linked to genetic alterations. Fanconi anemia is a rare genetic anemia characterized by pancytopenia resulting from defects in the DNA repair. This anemia develops early in life and is accompanied by multiple congenital anomalies. So again, our pathophysiology, therefore. The characteristic lesion of AA is a hypocellular bone marrow that has been replaced with fat. The pathogenesis of AA is not certain. Two etiologies and mechanisms are observed: an extrinsic immune-mediated suppression of bone marrow progenitor cells and the intrinsic abnormality of stem cells. The primary mechanism of acquired aplastic anemia involves immune-mediated destruction directed against hematopoietic stem cells. Several immune abnormalities are found in individuals, including dysregulated CD4, CD8, and Th17 T cell response, and reduced number of regulatory T cells. Additionally, many people have elevations of circulating levels of inflammatory or myelosuppressive cytokines, such as your interferon gamma, your tumor necrosing factor, and transforming growth factor beta. Although efforts have been identified circulating antibodies in acquired aplastic anemia individuals, the identification of autoantigens capable of eliciting cytotoxic T cells responses and causing stem cell destruction has been a challenge. Lab studies have focused on working model where activated T cells are suppressing your HSCs. Stem cells may be altered from exposure to drugs, infectious agents, and other unknown environmental factors. In many cases, no initiating factor can be identified, and therefore types of aplastic anemias belong in the idiopathic category. A genetic predisposition may involve polymorphism in humans, leukocyte antigens, and inhibitory cytokines. An emerging understanding suggests that the initial immune response may be triggered by pathogens, drugs, or chemicals, or by neoantigens through epigenetic mechanisms. It is interesting that transient and persistent bone marrow hypoplasia has been linked to many microorganisms, and the interaction and alterations between the gut microbiota and immune system is hypothesized as an initial insult in the development of bone marrow failure, syndromes such as aplastic anemia. So here we're taking a look at the working model of microbes, microbiota, and hematopoiesis, and the immune response. The evidence supporting an autoimmune process includes the response to AA to immunosuppressive therapy, including depletion of T cells by anti-thymocyte antibodies. Your cytotoxic T cells appear to be the main culprit, although the causative agent has yet to be identified. Your Th1 cytokines, such as your IFN gamma and TNF alpha, as well as the cellular contact with Tc cells through the FASL, induces apoptosis of CD34 plus target cells, which includes most of the hematopoietic progenitors. The presence of stem cell abnormalities is supported by the existence of abnormal karyotypes, short telomeres, and a low incidence of transformation of your aplastic anemia into myeloid neoplasms. So, how would your patient then present in terms of clinical manifestations with AA? The onset of symptoms is insidious and related to the rapidity with which the bone marrow is destroyed and replaced. Aplastic anemia affects both male and female at any age, so about 50% of AA cases progress rapidly with a high risk of death from the overwhelming infection or bleeding. In some cases, the rate of decline is slow, and the individual may adapt progressively to a new level of hematologic function. This condition is referred to as hypoplastic anemia rather than aplastic anemia. Initial symptoms depend on which cell line is affected. Rapidly progressing disease is usually associated with hypoxemia, your pallor, and weakness, along with the fever and dyspnea, with rapidly developing signs of hemorrhage if platelets are affected. So, again, you might have a lot of bleeding. A slower onset, over weeks or months, is characterized by progressive weakness and fatigue, with developing signs of hemorrhaging. Any kind of major hemorrhage may occur from any organ. However, it is generally observed in the late stages and is often secondary to other events. Menorrhagia and purpura also may be evident. However, purpura is not necessarily a classical indication of aplastic anemia and may not be representative of the degree of the thrombocytopenia. In both rapid onset and slow onset AA, diminished leukocyte production may result in a progressive frequency and prolongation of infections. Your late manifestations of the condition include the ulcerations of the mouth and the pharynx, or low-grade cellulitis in the neck. Splenomegaly is extremely rare. If it is present, however, other conditions may imitate AA, should be excluded. Neurological changes are only evident when hemorrhages have occurred within the system. However, some individuals have complained of paresthesias. So, your evaluation and treatment, therefore. Diagnosis should be made by blood tests and bone marrow biopsies. Your AA is suspected if levels of circulating erythrocytes, leukocytes, and platelets are all diminished. A granulocyte count less than 500, a platelet count less than 20,000, and an absolute reticulocyte count less than or equal to 40 times 10 to the 9th degree per liter. The diagnosis is confirmed by bone marrow biopsy. The bone marrow usually has a reduced cellularity. The morphology of the few remaining hematopoietic cells is usually normal. Occasionally, though, the erythrocytes are macrocytic, with an anisocytosis and poikilocytosis, and may appear immature. Marrow biopsied from individuals with typical AA contains yellowish-white material, consisting mainly of fat, fibrous tissue, and lymphocytes. Pancytopenia is usually characterized by decreased stem cell and progenitor cell populations to about 1% or less of normal. Up to 20 years ago, treatment involved determination of the cause, removal of the potential causative agent, implementation of transfusions, and the prevention and treatment of infection and hemorrhage. Stimulation of blood cell production also was used, and in some instances, a splenectomy was recommended. The prognosis with these forms of treatment were extremely poor. In acute cases, 25% of individuals succumbed within 4 months, and about 70% died within 5 years. Only about 10% experienced a complete recovery. However, newer forms of treatment, such as bone marrow transplant, immunosuppression, and the identification of high-risk individuals, have decreased mortality significantly. Bone marrow, and more recently, peripheral blood stem cell transplantation from the histocompatibility sibling often cures the underlying bone marrow failure. Your survival rates have increased 75 to 80%, and have been reported, and death rates within the first 100 days have decreased. Before transplantation, the recipient usually receives radiation or chemotherapy to deplete the bone marrow of disease-causing lymphocytes. Thus, an unsuccessful transplantation may leave the recipient with a depleted immune system and an increased vulnerability to infection. Your graft versus host disease remains a risk and is a major contributor to premature death. Children demonstrate higher survival rates than adults. For those individuals unable to undergo a bone marrow transplantation or who lack a suitable sibling donor, immunosuppression remains the treatment of choice. Your anti-thymocyte globulin specifically suppresses lymphocytes, including those autoreactive lymphocytes destroying the bone marrow cells. Drugs like cyclosporin, which is often used in combination with ATG, broadly suppress the activity of immune cells. Response rates of 40 to 50% may occur in individuals who receive ATG. The addition of cyclosporin has increased the response and survival rates to as much as 70 to 80%, with a 5-year survival rate between 80 to 90%. Cyclosporin as a single therapeutic agent is not as effective. Corticosteroids are often used concurrently with ATG and cyclosporin. Cyclophosphamide also has been used as an immunosuppressive agent and has produced the same effects as ATG. However, its use has been discontinued because of its toxicity. The addition of recombinant hematopoietic growth factors, such as granulocyte macrophage colony stimulating factor, your interleukin-6, and epoetin 2 immunosuppressive therapy, has produced significant additional benefit in both children and adults. Immunosuppressive therapy is not without risk. Individuals receiving immunosuppressive therapy are at risk of experiencing treatment failure or late clonal malignant conditions or both. Late clonal malignant conditions include paroxysmal nocturnal hemoglobinuria, myelodysplasia, acute leukemia, or a solid tumor. Although quite rare, administration of ATG may cause an anaphylactic reaction in some individuals. Hemolytic anemia, the predominant event in hemolytic anemias, is the premature acceleration destruction of erythrocytes, either episodically or continuously. A large majority of hemolytic anemias occur within phagocytes in lymphoid tissue called extravascular hemolysis. The destruction of senescent erythrocytes takes place within macrophages typically abundant in the spleen, bone marrow, and liver. Less common is intravascular hemolysis, caused by mechanical injury, complement fixation, intracellular parasites, or exogenous toxic factors. The consequences of anemia are elevated levels of erythropoietin to induce accelerated production of erythrocytes and an increase in the products of hemoglobin catabolism. Hemolytic anemias may be either congenital or acquired. Congenital hemolytic anemias result from intrinsic defects in erythrocytes, including the red cell membrane, enzymatic pathways, and hemoglobin synthesis. Acquired hemolytic anemias are usually immunologic, such as erythrocyte destruction caused by autoantibodies against erythrocyte antigens, isohemagglutinin, or allergic reactions against drug antigens absorbed onto the erythrocyte surface. Acquired hemolytic anemia may also be secondary to erythrocyte damage caused by cardiac valve prostheses or by increased shear stress in narrowed small vessels. Your causes of acquired and hereditary hemolytic anemias are listed here in the following table. So it's a good spot to hit pause and you can kind of review the causes of hemolytic anemias. So what is the pathophysiology? The extravascular hemolysis appear to be initiated by age-related changes in erythrocyte surface proteins, leading to their recognition and phagocytosis. Erythrocytes continuously circulate through the spleen, passing through the thin-walled splenic cords into the splenic sinusoids, or sponge-like labyrinths of macrophages. Normally, erythrocytes are able to alter their shape to allow passage through openings in the splenic cords. Macrophages will phagocytose erythrocytes with structural alterations of the membrane surface, or erythrocytes may become more rigid and therefore incapable of maneuvering through this network. In some cases, IgG antibodies or complement components, your C3b, can coat erythrocytes without causing hemolysis, but can function as opsonins that are recognized by macrophages. Intravascular hemolysis is caused by physical destruction of erythrocytes in the circulation, frequently by antibody and complement. As mentioned earlier, other forms of destruction include mechanical injury, such as shear stresses and narrowed microcirculation, repetitive physical trauma, or trauma caused by cardiac valves. Intracellular parasites, such as Plasmodium falciparum, malaria, can cause intravascular hemolysis because infection may generate early elimination of normal or non-parasitized red blood cells, lysis of the parasitized red blood cells, and impairment of erythropoiesis. Toxic injury, such as a form of snake venom, contains hemolytic toxins, and clostridial sepsis results in the release of enzymes that digest the erythrocyte membrane. Your paroxysmal nocturnal hemoglobinuria, although rare, is the only hemolytic anemia caused by an acquired genetic defect that is manifested by complement-mediated hemolysis. It may be congenital or acquired secondarily to acquired aplastic anemia. The disease results from a mutation in the X-linked gene for phosphatidylinosytol glycan class A, also known as PIGA, which results in a defect of expression on the glycophosphatidylinosytol in hematologic stem cells, also known as GPI. GPI is a lipid anchor that is necessary for attachment of large number of proteins to the plasma membrane. Several GPI-anchored proteins on the erythrocyte are complement regulatory proteins, including the CD55 and CD59. Normally, low levels of complement are activated on cell surface through the alternative pathway. Erythrocytes are protected from complement-mediated damage by the CD55, which accelerates the degradation of any C3 convertase that forms on the cell surface, and by CD59, which prevents C9 aggregation and pore formation by the membrane attack complex. So therefore, erythrocytes deficient in the CD55 and 59 undergo complement-mediated intravascular lysis and release of hemoglobin. Your peptide inhibitors of C3 activation that may prevent hemolysis are under investigation. In addition to anemia and hemoglobinuria, affected individuals also present with severe fatigue, abdominal pain, and thrombosis. The cause of death is usually thrombosis of the abdomen or cerebral veins. Thrombosis most likely results from a depletion of vascular nitric oxide by free hemoglobin, which has a high affinity to nitric oxide. The result is dysregulation of normal hemostasis and increased platelet vascular adherence and clot formation. Immunohemolytic anemias, also called autoimmune hemolytic anemias, are acquired disorders caused by autoantibodies or complement, or a combination of both, on red cells against antigens normally on the surface of the erythrocyte. Immunohemolytic anemia is the preferred term because in some instances the immune reaction is initiated by an ingested drug. Three types of AIHAs have been described: warm reactive antibody type, cold agglutinin type, and cold hemolysin type. This classification is based on the optimal temperature at which the antibody binds to erythrocytes and the mechanism of erythrocyte destruction. Warm autoimmune hemolytic anemia is considered uncommon, although it is the most common form of IHA. The general occurrence in individuals older than the age of 40 is about 80 to 90%, but it's only 1 in 80,000. Roughly half of the cases are secondary to other kinds of diseases, usually lymphomas, but also chronic lymphocytic leukemias, other neoplastic disorders, or systemic lupus erythematosus. The anemia is caused by an IgG that binds optimally to the erythrocyte at a normal body temperature. Most cases are related to antibody against Rh-related antigens, other than the D epitome. The spectrum of antibody specificity includes antibodies against the E, or C antigens of the Rh complex. Other cases are caused by IgG antibodies against erythrocyte antigens outside the Rh complex and include antibodies against WRB, ENA, and the KEL blood group, and many others. The warm reactive IgG antibodies usually do not activate complement because of the rather sparse distribution of antigens on the erythrocyte surface. Erythrocyte destruction is caused by extravascular processes. The IgG-coated erythrocytes bind to the Fc receptors on monocytes and splenic macrophages and are removed by phagocytosis. Cold agglutinin autoimmune hemolytic anemia is mediated by the immunoglobulin M antibodies and occurs less often than warm antibody hemolysis, affecting mostly middle-aged or older adults. Cold antibodies optimally bind to erythrocytes at colder temperatures. Cold agglutinin autoantibodies may appear acutely during recovery of certain infectious disorders, particularly infectious mononucleosis, Mycoplasma pneumoniae, and disseminating tuberculosis. Individuals with these conditions are usually younger than those with the primary disease. The anemia may be severe, but may be self-limiting. Chronic cold agglutinin AIHAs also can occur in association with lymphoid neoplasm and other unknown or idiopathic conditions. The IgM autoantibody is usually monoclonal and directed against erythrocyte carbohydrate antigens of the I system or the P system. In the colder areas of the body, particularly during cold weather, the IgM autoantibodies bind to circulating erythrocytes. The IgM is rapidly released when the blood recirculates and warms. IgM is an extremely efficient activator of complement, resulting in the stable deposition of the C3b on the cell surface. If an adequate amount of complement is deposited, the erythrocyte becomes vulnerable to recognition and rapid phagocytosis by mononuclear phagocytes in the liver and spleen. The severity of hemolysis is variable and may result in a progressive chronic anemia. If the level of the antibody is high or has particularly strong binding, hemagglutination may occur in the capillaries of exposed sites such as the fingers, the toes, and ears when temperatures are below 30 degrees Celsius. Obstruction of blood flow caused by erythrocyte agglutination may lead to a bluish discoloration of the skin that resolves as the skin is warmed. Prolonged exposure to the cold may lead to gangrene. Your cold hemolysin autoimmune hemolytic anemia is a disorder in which exposure to cold initiates acute and severe intravascular hemolysis that, unlike cold agglutinin anemia, results in hemoglobinuria. The chronic form of this anemia is extremely rare, but an acute form of paroxysmal cold hemoglobinuria is frequently observed in AIHA of childhood. The acute form occurs primarily in children younger than the age of 10 and is usually preceded by an upper respiratory tract infection or flu-like symptoms. Infections with measles, mumps, mycoplasma, and varicella have been linked to an onset of paroxysmal cold hemoglobinuria. The anemia may be rapidly progressing and severe and associated with fever, reddish-brown urine, hemoglobinuria, jaundice, abdominal pain, and pallor, with about 25% of these individuals presenting with a hepatomegaly and splenomegaly. Paroxysmal cold hemoglobinuria is generally caused by IgG autoantibodies against the P blood group antigen. Antibody binding occurs in the colder portion of the body. As the erythrocyte recirculates, enzymes of the complement cascade are activated, and the cells are destroyed in the vasculature by complement-mediated lysis. The involved antibody, also called the Donath-Landsteiner antibody, was first recognized in individuals with anemia secondary to chronic syphilis infections. A transfusion reaction is an example of an alloimmune hemolytic anemia. Transfused blood that is mismatched for ABO antigens is destroyed by pre-existing isohemagglutinin in the recipient. Isohemagglutinin, which are generally IgM antibodies, activate complement, resulting in a rapid intravascular hemolysis. The individual may immediately experience fever, chills, dyspnea, and hypotension, and may progress to shock. In some cases, the hemolytic reaction may be delayed and develop 3 to 10 days after the transfusion. The delayed reaction is caused by a low titer of pre-existing antibodies to minor erythrocyte antigens. Drug-induced hemolytic anemia is a form of an immune hemolytic anemia, usually resulting from an allergic reaction against foreign antigens. Usually, the drug is low molecular weight, functions as a hapten, and binds to proteins on the surface of erythrocytes. This is sometimes called the hapten model and is based on anemia caused by penicillins, cephalosporins, and hydrocortisone. IgG antibody against the drug or against a unique antigen formed by the interface of the drug and erythrocyte protein is formed and binds to the erythrocyte at normal body temperature. Hemolysis is usually extravascular because the opsonized erythrocyte are removed by phagocytes in the spleen and liver. Although complement-dependent, intravascular hemolysis may occur in some individuals. This form of drug-induced anemia usually follows a large intravenous infusion of an antibiotic and occurs in 1 to 2 weeks after the initiation of the therapy. Cessation of administration of the drug results in rapid resolution of anemia. So here you're taking a look at models of drug-induced hemolytic anemia. The erythrocyte plasma membrane contains receptors of components of the complement system, such as the C3b, and combined circulating immune complexes that activated the complement cascade. Thus, forms the basis for the immune complex model of drug-induced hemolytic anemia and was first described for anemia resulting from administration of a drug quinidine, the drug or a metabolite of the drug, both of which are haptens, initially binds to plasma proteins and become immunogenic. The circulating drug protein complex reacts with the resultant antibody and activates the complement system, resulting in the deposition of the C3b into the complex. Binding of the immune complexes to the erythrocyte surface results in further complement activation and intravascular hemolysis. This mechanism also may explain some of the anemia observed in other immune complex conditions, such as SLE. In at least one instance, administration of drug alpha methyl-dopa induces an immune response against normal erythrocyte antigens and thus initiates a true AIHA. The autoantibody is usually against Rh blood group antigens. It is estimated that about 20% of individuals taking an alpha methyl-dopa develops detectable antibodies, but only 1% actually develops clinically significant anemia. The mechanism by which the alpha methyl-dopa induces autoantibodies against the erythrocytes is still unknown. So, clinical manifestations. The presence and severity of signs and symptoms of hemolytic anemia all depend on the degree of the anemia and hemolysis and the success of the compensatory erythropoiesis. Adaptation to red cell destruction is facilitated by increased red cell production. Bone marrow is capable of increasing red cell production up to 8 times its normal rate. Accelerated erythrocyte production that is incapable of keeping up with destruction develops into a true hemolytic anemia. The severity of anemia varies widely among individuals, even if those who have the same illness. Severe disease is commonly diagnosed shortly after birth or within the first year of life. Mild to moderate anemia is more common because the shortened erythrocyte survival time is offset by increased erythropoiesis. Some individuals have no symptoms of anemia, and the underlying hemolytic process remains undetected unless some other complications develop during the course of the disease. Jaundice is present when heme destruction exceeds the liver's ability to conjugate and excrete the bilirubin. Jaundice is often first noticed in the neonatal period. Children and adults with congenital hemolytic anemia may not have icterus, or it may be mild enough that it remains unnoticed. In some individuals, faint scleral icterus may be the only indication of hemolytic disease. Acute conditions that disrupt the delicate equilibrium of accelerated erythropoiesis and erythrocyte destruction may precipitate a crisis. The most common type of crisis is aplastic and results from failure of bone marrow erythrocyte production. The most common cause of aplastic crisis is the human parvovirus, the B19 infection. Commonly, individuals with congenital hemolytic disorders demonstrate splenomegaly, which is often mild in nature. In some cases, the spleen may become quite enlarged and may cause discovery of the underlying hemolytic disorder. Another underlying condition that may be the cause of inadvertently determining the presence of the anemic disorder is the development of gallstones. Children who have hemolytic anemia often demonstrate skeletal abnormalities caused by expansion of erythroid bone marrow during the active phase of growth and development. These alterations are more pronounced in the bony structures of the face and skull and may result in pathologic fractures. Cardiovascular and respiratory manifestations vary with the degree of anemia. In spite of the disorder being characterized as hemolytic in nature, thromboembolism may occur. Here, pulmonary embolism is a common finding during autopsies of individuals with immune hemolytic anemia. So its evaluation and treatment, therefore. Diagnosis is based on clinical manifestations, bone marrow studies, and blood tests. Abnormally increased numbers of erythrocyte stem cells are found in the marrow, a finding termed erythroid hyperplasia. Accelerated erythropoiesis causes large numbers of fragile and immature erythrocytes to be released prematurely into the circulation. These cells are observed in blood smears. If the bone marrow is able to consistently maintain adequate compensation, the hemoglobin may remain stable. The mean corpuscular volume, however, may be decreased in the presence of reticulocytes. A blood smear is helpful in determining the presence of spherocytes and schistocytes, as well as examining white blood cells and platelets for coexisting hematologic or malignant conditions. Acquired hemolytic anemias are treated by removing the cause or treating the underlying disorder. Corticosteroids are used for initial treatment. Roughly 75% of individuals initially respond to the treatment of corticosteroids, but many of these patients relapse within a year. The most common used second-line treatment are splenectomy and administration of rituximab. A splenectomy is performed if the spleen is the major site of hemolysis and splenomegaly is significant. Analysis of multiple studies confirms that some response is achieved in between 59 and 100% of individuals. Although some individuals relapse after a splenectomy, most achieve a long-term remission. The therapeutic use of a monoclonal antibody has proven beneficial in individuals who relapse or are resistant to the effects of corticosteroids. Rituximab is a monoclonal antibody directed against the CD20 antigen and specifically depletes or suppresses B cells throughout the entire body. CD20 is expressed on most cells in the B cell lineage, except hematopoietic stem cells and the plasma cells. Rituximab is used to treat a variety of leukemias and lymphomas and autoimmune diseases. It is used successfully in several types of immune hemolytic anemias. Eculizumab is a monoclonal antibody against complement protein C5, which blocks enzymatic activation of C5 to C5a and C5b, and thus may be useful in the treatment of paroxysmal nocturnal hemoglobinuria. Treatment with eculizumab prevents the formation of membrane attack complex and complement-mediated cell lysis. Acute fulminating hemolytic anemia is treated with fluid and electrolyte replacement to prevent shock and renal damage, which may be caused by erythrocyte debris clogging the kidney tubules. Transfusions of blood products sometimes are given. Folate also is used in the treatment of chronic hemolytic disease to prevent megaloblastic crisis, because the long-term erythrocyte turnover increases folate requirements. That brings us to the myeloproliferative red blood cell disorders. Hematologic dysfunction results from an overproduction of cells as well as a deficiency One or more hematopoietic lines may be overproduced in the marrow in response to exogenous or endogenous signals. Excessive red blood cell production is classified as polycythemia. Polycythemia exists in two forms, a relative and an absolute. Relative polycythemia results from a hemoconcentration of the blood associated with dehydration that may be caused by a decreased water intake, diarrhea, excessive vomiting, or increased use of diuretics. It's usually a development of a minor consequence and resolves with fluid administration or treatment of the underlying condition. An absolute polycythemia, however, consists in two forms as well, primary and secondary. Secondary polycythemia, the more common type, is a physiologic response resulting from increased erythropoietin secretion in response to chronic hypoxia. This hypoxia is noted in individuals who live at higher altitudes, so smokers with increased levels of carbon monoxide and individuals with chronic obstructive pulmonary disease or congestive heart failure, or a combination of both. Abnormal types of hemoglobin, which have a greater affinity for oxygen, also can cause secondary polycythemia, as does the secretion of erythropoietin by certain tumors. Polycythemia vera, or PV, is one of the several disorders collectively known as a chronic myeloproliferative disorder. Others in this group include essential thrombocytosis, chronic idiopathic myelofibrosis, chronic myeloid leukemia, chronic neutrophilic leukemia, and chronic eosinophilic leukemia. All results from abnormal regulation of the multipotent hematopoietic stem cell. The major characteristics shared by these disorders are the involvement of multipotent hematopoietic progenitor cells and the overproduction of one or more of the formed elements of the blood in the absence of a defined stimulus. It also can be defined by the dominance or transformed progenitor cells over the non-transformed progenitor cells. Emeral hypercellularity or fibrosis, cytogenic abnormalities, predisposition to thrombus formation and hemorrhage, and finally, spontaneous transformation to acute leukemias. PV is quite rare with an estimated incidence of only 2.3 per 100,000 individuals. Peak incidence is between the ages of 60 and 80 years, with a median incidence in individuals aged 55 to 60. However, PV has been observed in individuals younger than the age of 40. Males are more likely to develop it than females. PV also is more common in whites than in blacks, particularly whites of Eastern European Jewish ancestry. PV is rarely found in children or in multiple members of a single family. However, an autosomal dominant form exists that is characterized by increased production of erythropoietin. So what is its pathophysiology? PV is a chronic, neoplastic, non-malignant condition characterized by the overproduction of red blood cells, white blood cells, and platelets, and splenomegaly. Erythrocytosis is the essential component of PV. Clonal proliferation of erythroid progenitors occurs in the bone marrow, independent of erythropoietin, although the cells express a normal erythropoietin receptor. However, more than 95% of individuals with PV possesses an acquired point mutation in the Janus kinase 2 gene, or the JAK2. A cytoplasmic tyrosine kinase on chromosome 9, JAK2, increases the activity of the erythropoietin receptors and is a self-regulatory so that JAK2 activity can diminish over time. The mutation associated with PV negates the self-regulatory activity of the JAK2 so that the erythropoietin receptor is constitutively active regardless of the level of erythropoietin. These red blood cells, precursors, also demonstrate sensitivity to other growth factors, such as interleukin 3, granulocyte macrophage, colony stimulating factor, or insulin like growth factor. Very recent data suggests that erythropoietin could stimulate the proliferation of cells expressing JAK2 and the phosphorylation of 3-tyrosine residues in the erythropoietin receptor underlying JAK2 point mutation induced tumorigenesis. So, what kind of clinical manifestations do we see? Almost every individual initially presents with an enlarged spleen, frequently with abdominal pain and discomfort. As the disease progresses, many of the symptoms are related to the increased blood cellularity and its viscosity. Increased viscosity, as well as thrombocytopenia and increased platelet dysfunction, leads to a hypercoagulable state with formation of venous and arterial thrombosis and vessel occlusion. Endothelial cells carrying the JAK2 mutation suggests that endothelial cells are involved in the pathogenesis of the myeloproliferative neoplasm. Thrombi, with occlusion of major and minor blood vessels, lead to tissue and or organ injury and death. Extreme thrombocythemia increases the risk for excessive bleeding rather than thrombosis. Increased blood viscosity results in a variety of circulatory alterations in PV, such as plethora and engorgement of the retinal and cerebral veins. Individuals also may experience headaches, drowsiness, delirium, mania, psychotic depression, chorea, and visual disturbances. Death from cerebral thrombosis is increased approximately fivefold in individuals with PV. Cardiac workload and output remain essentially unchanged. However, increased blood volume may lead to elevated blood pressure. Coronary blood flow may be affected, precipitating angina, although cardiovascular infarctions are relatively rare. Other evidence of cardiovascular involvement is the development of Raynaud phenomenon and the thromboangiitis obliterans. Additionally, gastrointestinal gastric and duodenal thrombosis may occur with resultant hemorrhaging. The development of mesenteric thrombosis requires immediate medical intervention. Splenomegaly and hepatomegaly result from pooling of blood in these organs. Consequently, individuals may develop portal hypertension. The respiratory system is generally not affected by PV unless thrombosis and embolization occur. A unique feature of PV, one helpful in diagnosis, is the development of intense, painful itching that is intensified by heat or exposure to water, particularly warm water when bathing or showering. The intensity of the itching is related to the concentration of the mast cells in the skin and is generally not responsive to antihistamines or topical lotions. So, how would you evaluate and treat it then? PV is frequently suspected on the basis of clinical features, such as the thrombotic event, splenomegaly, or aquagenic pruritus. Diagnosis of PV is made from blood and lab findings. An absolute increase in the number of red blood cells and the total blood volume confirms the diagnosis. The hemoglobin concentration ranges from 14 to 28, and the hematocrit is usually 60% or higher. Erythrocytes appear normal, but anisocytosis may be present. A bone marrow examination may be done, but is not very valuable unless performed in association with a cytogenic and molecular study for relevant mutations in the JAK2. The presence of JAK2 mutation confirms the diagnosis. Typically, the marrow is hypercellular, but not in such a manner as to differentiate it from other myeloproliferative disorders. Additionally, observations of abnormal megakaryocyte morphologies, formation of clusters of abnormal cells, and increased fibrosis add more specificity and usefulness to bone marrow analysis. Elevated serum levels of erythropoietin are not helpful because most individuals with PV have normal or low levels. Treatment of PV is challenging and directed towards minimizing the risk of thrombosis and preventing progression to myelofibrosis and acute leukemias. In low-risk individuals, the recommended therapy is a phlebotomy and a low-dose aspirin. Initial phlebotomies are done 2 to 3 times a week until the hematocrit drops sufficiently and repeated every 3 to 4 months to maintain a safe hematocrit level, that of less than 45%. Aspirin is used as an antithrombotic property. Hydroxyurea, an antimetabolite that blocks DNA synthesis and reduces vascular cellularity, is the drug of choice for myelosuppression. Unlike other similar drugs, hydroxyurea reduces the risk of thrombotic complications, but does not increase the risk for developing leukemia. Radioactive phosphorus has been used to suppress erythropoiesis. Its effects can last up to 18 months. Side effects of radioactive phosphorus, however, treatment include the suppression of hematopoiesis resulting in anemia, leukopenia, and thrombocytopenia. Acute leukemia also is a side effect, although most often it occurs after 7 or more years of treatment, making this therapy more useful in the elderly. Interferon alpha has been used when other forms of treatment have failed. Interferon inhibits the growth of the abnormal progenitors and inhibits the actions of cytokines that may lead to the development of myelofibrosis. Therapy of interferon alpha is complicated by the pro-inflammatory activities. Thus, fever, flu-like symptoms, and more severe complications are common. Interferon alpha is not consistently effective in high-risk adult cases, but is considered in individuals who are intolerant to hydroxyurea, younger individuals, as well as individuals who may be pregnant. Treatment with inhibitors of the JAK2 pathway has resulted in the reduction of many associated disease symptoms and a significant improvement in the quality of life. However, the optimal target defining successful treatment and the effects on the lifespan have not yet been determined. Recent studies comparing the effects of phlebotomy and/or hydroxyurea, or the combination of both, concluded that the goal of maintaining a hematocrit less than 45 degrees was preferable to the goal of 45 to 50%. The lower target goal resulted in a significantly lower rate of death from cardiovascular causes or major thrombotic events. Survival for 10 to 15 years is usually common. However, without proper treatment, 50% of individuals with PV die within 18 months of the onset of initial symptoms. The primary cause is thrombosis, which is more prevalent in elderly individuals and those with prior vascular complication. Death because of a hemorrhage is rare, but more common in individuals with high platelet counts and those taking antiplatelet drugs. Conversion to acute myeloid leukemia occurs spontaneously in 10% of individuals within 15 years, increasing to 50% within 20. This leukemia is generally refractory to conventional treatment. Conversion to AML is most likely related to treatment with cytotoxic myelosuppressive agents, such as chlorambucil. Those individuals treated with an alpha interferon or hydroxyurea had the same incidence of conversion as those who received no treatment. Although PV is a chronic disorder, appropriate therapy results in remission and prevention of significant morbidity. Bringing us to an iron overload. Iron overload can be primary in the hereditary hemochromatosis or secondary. The secondary causes of iron overload include parental iron overload in conditions such as anemias with inefficient erythropoiesis, dietary iron overload, or other conditions that require repeated blood transfusion or iron dextrin injections. Hereditary hemochromatosis is a common inherited autosomal recessive disorder of iron metabolism and is characterized by increased gastrointestinal iron absorption with subsequent tissue iron depositions. Excess iron is deposited in the liver, pancreas, heart, joints, and endocrine glands, causing tissue damage that can lead to diseases such as cirrhosis, diabetes, heart failure, arthropathies, and impotence. Hereditary hemochromatosis, or HH, is caused by two genetic pair alterations, the C282Y and the H63D. These are mutations in the HFE gene on chromosome 6. Homozygosity of C282Y is the most common genotype and accounts for 82 to 90% of HH cases. The remaining cases appear to be caused by environmental factors or other genotypes. HFE mutations are common in the US, with 1 in 10 white individuals heterozygous for the HFE C282Y mutation and 4.4 in 1,000 homozygous for the C282Y mutation. That C282Y homozygosity is much lower among Hispanics, Asian Americans, Pacific Islanders, and African Americans. So, what is the pathophysiology? Studies in mice have confirmed that the HFE gene is responsible for the majority of adults' form of HH. The HFE protein found in the crypt cells of the duodenum facilitates interferon receptors dependent iron uptake into crypt cells. The HFE protein regulates the production of the protein hepcidin, considered the master regulator of iron. The C282Y mutation prevents the altered HFE protein from reaching the cell surface, preventing interaction with the hepcidin and transferrin receptors. The deficiency results in an increase in the expression of an iron transport protein, divalent metal ion transporter 1, which is responsible for dietary iron absorption in the villus cells of the small intestine. This inappropriate intestinal iron absorption leads to iron overload and eventually end organ damage that can result in cirrhosis, diabetes, hypothyroidism, cardiomyopathies, and arthritis. Although the natural history of HH is emerging, there appears to be a long latent period with individuals' variations in biochemical expression modified by environmental factors, such as blood loss from menstruation or donation, your alcohol intake, as well as your diet. Cirrhosis is a late-stage development of HH that can shorten life expectancy. Cirrhosis also is a risk factor for hepatocellular carcinoma that occurs in individuals between the ages of 40 and 60 years. Cirrhosis prevention is a major goal of HH screening and treatment. So, your clinical manifestations, therefore, of HH include symptoms of fatigue, malaise, abdominal pain, arthralgias, and sometimes amenorrhea in women and loss of libido or impotence in men. Clinical findings of HH include hepatomegaly, abnormal levels of liver enzymes, bronze skin, altered glucose homeostasis or diabetes, and cardiac dysfunction. Many individuals are diagnosed as a result of serum iron studies as part of a health screening panel. Most individuals are asymptomatic and have a low level frequency of cirrhosis, diabetes, or skin pigmentation. So it's evaluation and treatment, therefore. Lab findings in individuals with HH show elevations in serum iron levels, transferrin saturation, and ferritin levels. Documentation of iron overload relies on quantitative phlebotomy with calculations of amount of iron removed, or liver biopsy with determinations of quantitative hepatic iron. With the advent of genetic testing, no further workup is necessary in individuals who are C2A2Y homozygous or compound heterozygous, are less than 40 years old, and have normal liver function. Treatment of HH is simple and consists of phlebotomy of about 550 ml of whole blood, which is the equivalent of 200 to 250 milligrams of iron. Frequency of phlebotomy depends on the ferritin level and should continue until the ferritin level is between 20 and 50. Initially, phlebotomy may be needed weekly, but once therapeutic ferritin levels are reached, phlebotomy may be only needed every 2 to 3 months. Blood banks now accept blood donations from persons with documented HH. Iron chelating agents are sometimes used in addition to phlebotomy, but this is not the mainstay of treatment. Individuals with HH should be instructed to refrain from taking iron and vitamin C supplements and consuming raw shellfish. In addition, alcohol should be used in moderation. Family screenings is recommended and necessary for all first-degree relatives of a person with HH. So, alterations of platelet and coagulation. Hemostasis is dependent on the adequate number of platelets and levels of coagulation factors. Diminished or excessive levels may lead to defective hemostasis and spontaneous and unnecessary activation of clotting. Diminished homeostasis results in either internal or external hemorrhage. Diffuse hemorrhage into skin tissue that is visible through the skin causes a red-purple discoloration, identified as purpura. Purpuric disorders occur when there are not enough normal platelets to plug damaged vessels or prevent a leakage from the many minute tears that occur daily in normal capillaries. Disorders of the clotting system tend to result in more serious internal bleeding than platelet defects and are usually caused by a deficiency of one or several clotting factors. Disorders that result in spontaneous clotting can result from genetic disorders of clotting systems components or from acquired diseases that activate clotting. These disorders are known collectively as thromboembolic diseases. Disorders of platelets, quantitative or qualitative abnormalities of platelets can interrupt normal coagulation and prevent homeostasis. The quantitative abnormalities of thrombocytopenia and thrombocythemia. Qualitative disorders affect the structure or function of individual platelets and can coexist with quantitative disorders. Qualitative disorders usually prevent platelet adherence and aggregation, preventing formation of a platelet plug. Thrombocytopenia. Thrombocytopenia is defined as a platelet count less than 150,000 platelets of blood. Although most healthcare providers do not consider the decreased significance unless the count falls less than 100,000. Hemorrhage resulting from minor trauma does not usually occur until the count falls below 50,000. Spontaneous bleeding without apparent trauma can occur with counts between 10 to 15,000, resulting in petechiae, ecchymosis, larger purpuric spots, or frank bleeding from mucous membranes. Severe spontaneous bleeding may result if the count is less than 10,000 and can be fatal if it occurs in the gastrointestinal tract, respiratory tract, or central nervous system. Before the diagnosis of thrombocytopenia is made, pseudothrombocytopenia must be ruled out. The phenomenon occurs in approximately 1 in 100,000 to 1 in 10,000 lab samples and is an in vitro artifact that may occur when a blood sample is analyzed by an automated cell counter. Platelet in the sample may become nonspecific agglutination by immunoglobulins in the presence of ethylene acid, or EDTA, a preservative in banked blood. The Agglutinated platelets are not counted, thus giving an apparent but false thrombocytopenia. Thrombocytopenia also may be falsely diagnosed because of a dilutional effect observed after massive blood transfusion and platelet-poor packed cells to treat a hemorrhage. This occurs when there is more than 10 units of blood have been transfused within a 24-hour period. The hemorrhage that necessitates the transfusion also accelerates the loss of platelets, which further contribute to the pseudo-thrombocytopenic state. Splenic sequestering of platelets secondary to hypersplenism induces an apparent thrombocytopenia, as does hypothermia, which is reversed when temperatures return to normal, suggesting an increased platelet sequestration in response to chilling. So the pathophysiology. Thrombocytopenia results from decreased platelet production, increased consumption, or both. The condition also may be congenital or acquired and primary or secondary to other acquired or congenital conditions. Thrombocytopenia secondary to congenital conditions occurs in a large number of different diseases, although each is relatively rare. These include thrombocytopenia with absence of radius syndrome, Wiskott-Aldrich syndrome, various formations of the MYH9 gene mutation, the X-linked thrombocytopenia, and many other examples. Acquired thrombocytopenia is more common and may occur as a result of decreased platelet production secondary to viral infections, your nutritional deficiencies, as well as chronic renal failure, bone marrow hypoplasias, radiation therapy, or bone marrow infiltration via cancers. The most common form of a thrombocytopenia are the result of increased platelet consumption. So examples include heparin-induced thrombocytopenia, idiopathic thrombocytopenic purpura, and thrombotic thrombocytopenic purpura. So your heparin-induced thrombocytopenia. Heparin is a common cause of drug-induced thrombocytopenia. About 4% of individuals treated with an unfractionated heparin development heparin-induced thrombocytopenia, or HIT. The incidence is lower with the use of low molecular weight heparin. HIT is an immune-mediated adverse drug reaction caused by IgG antibodies against the heparin platelet factor IV complex, leading to platelet activation through platelet Fc gamma 2A receptors, the release of additional platelet factor IV from activated platelets and activation of thrombin lead to an increased platelet consumption and a decrease in platelet count, beginning about 5 to 10 days after the administration of heparin. So here's a picture of the pathogenesis of HIT. So the hallmark clinical manifestations of HIT is thrombocytopenia, a decrease of about 50% in the platelet count, as seen in more than 95% of individuals. However, 30% or more of those with thrombocytopenia also are at risk for venous or arterial thrombosis. Venous thrombosis is the most common and result in DVTs and pulmonary emboli, or PEs. Arterial thrombosis affect the large arteries of the lower extremities, causing acute limb ischemia. Arterial thrombosis also may lead to a cerebrovascular accident and myocardial infarction. Other major arteries also may be affected. Bleeding is uncommon in HIT, even with the low platelet count. So its evaluation and treatment, therefore. Diagnosis is primarily based on clinical observations. The individual presents with a dropping platelet count after 5 days or longer with heparin treatment. On average, platelet counts may reach 60,000 because most individuals are post-surgery and the onset of symptoms include thrombosis, may be delayed until after the release from the hospital. Other possible causes of thrombocytopenia must therefore be considered. Tests are available to measure antibodies against heparin platelet factor 4. The test sensitivity is extremely high, but the specificity is less because of false positive reaction. Hit antibody titers may be measured, but the titers must be evaluated in the context of the clinical presentation. If hit is not recognized and treated, intravascular aggregation of platelets causes rapid development of arterial and venous thrombi. Although rare, heparin antibodies have caused anaphylactic shock. Treatment is the withdrawal of heparin and the use of an alternative anticoagulant. A switch to a low molecular weight heparin is not indicated, and warfarin or Coumadin should not be used until the symptoms of HIT have resolved because of the increased risk of initiating skin necrosis. The thrombocytopenia should progressively resolve. The chance of spontaneous blood clots can be diminished using a thrombin inhibitor. So, are immune thrombocytopenic purpura the most common cause of thrombocytopenia secondary to increased platelet destruction is the immune thrombocytopenic purpura, or ITP. The incidence of ITP is estimated to be about 5.8 to 6.6 per 100,000 in general populations. ITP was formerly known as idiopathic thrombocytopenic purpura. However, it is widely recognized now as an immune process, hence the change from idiopathic to immune. ITP may be acute or chronic. The acute form is frequently observed in children and typically lasts 1 to 2 months with a complete remission. In some instances, it may last up to 6 months in some children and may progress to a chronic condition. Acute ITP is usually secondary to an infection, particularly viral infections, or other conditions that lead to large amounts of antigens in the blood, such as your drug allergies or systemic lupus erythematosus. Under these conditions, the antigen usually forms immune complexes with circulating antibodies, and it is thought that the immune complexes bind to Fc receptors on platelets, leading to their destruction in the spleen. The acute form of ITP usually resolves as the source of antigen is removed. Chronic ITP is associated with autoantibodies against platelet-specific antigens. This form is more commonly observed in adults, with the highest prevalence in women between 20 and 40 years old, although it can develop at any given age. The chronic form tends to be progressively worse. The autoantibodies are generally that of IgG, although IgA and IgM antibodies have now been identified. They react against one of or more of the several platelet glycoproteins. The antibody-coated platelets are removed from the circulation by mononuclear phagocytosis in the spleen through the Fc receptor. So the clinical manifestations, therefore, are usually minor bleeding problems that occur over the course of several days and progress to major hemorrhage from mucosal sites. Rarely will an individual present with intracranial bleeding or internal bleeding at other sites. During pregnancy, an individual with ITP may have a newborn that is also thrombocytopenic. In most individuals, the antiplatelet antibody is the IgG that readily crosses the placenta. If the fetal platelets express the same antigen as the mother, the maternal antibody will coat the platelets, potentially resulting in a thrombocytopenia in utero. A variant of neonatal thrombocytopenia occurs when the mother does not have ITP, but makes IgG antibodies against an antigen inherited from the father and found on fetal platelets, but not on maternal platelets. Alloimmune neonatal thrombocytopenia occurs in 1 of 2,000 pregnancies. The most common antibody in this condition is against the human platelet antigen on the GP3A protein. Neonatal thrombocytopenia, either secondary to maternal autoimmune thrombocytopenia or as an alloimmune thrombocytopenia, may occur to various degrees. The most severe form results in fetal platelet counts below 20,000 with a high associated risk of intracranial hemorrhage. So, how do we evaluate and treat it, therefore? The diagnosis of ITP is based on the history of bleeding and associated symptoms such as weight loss, fever, and headaches. Physical exam include notation on the types of bleeding, location, and severity. Assessment includes determination of a history of infection, as well as a medication history and family history. Evidence of thrombosis also is assessed. Diagnostic tests include complete blood count and peripheral blood smears. Unlike some other forms of thrombocytopenia, splenectomy is rarely observed. Testing for antiplatelet antibodies is usually not helpful, although most cases of ITP are associated with elevated levels of IgG on platelets. Other forms of thrombocytopenia also have a high incidence of platelet-associated antibodies, thus the specificity is low. In addition, some cases of ITP will not present with elevated platelet-associated antibodies. The sensitivity is 75 to 94%, so that a negative test does not completely rule out ITP. The acute form of ITP usually resolves without major clinical consequences. As with most autoimmune diseases, the course of chronic form is variable, with multiple remissions and exacerbations. For many individuals, the platelet count may remain adequate enough to avoid clinically serious bleeding. However, the presence of spontaneous bleeding suggests that more severe diseases and requires immediate attention. Treatment is initiated when platelet counts are less than 30,000 or less than 50,000 with evidence of bleeding from mucous membranes or when the individual is at a high risk to develop bleeding. Treatment is palliative, not curative, focusing on the prevention of the platelet destruction. Initial therapy for ITP is an infusion of glucocorticoids, which suppresses the production of antiplatelet antibodies and prevents sequestering and further destruction of platelets. If platelet count does not increase appropriately, other medications may be tried. Treatment with intravenous immunoglobulin is used to prevent major bleeding. The response rate is usually 80%, but the effects are transient, lasting only days or a few weeks. Your anti-Rh immune globulin, which is a preparation of antibody against the D antigen of the Rh blood group, has been used with limited success to treat individuals who are Rh positive. Newer treatments include romiplostim and eltrombopag. Both drugs are thrombopoiesis stimulating Fc peptide fusion proteins. Romiplostim is administered subcutaneously, and eltrombopag is taken orally. These drugs increase platelet counts and decrease bleeding. Romiplostim is often used as a second-line treatment after IVIG or in individuals who experience relapse post-splenectomy. If all other therapies are ineffective, splenectomy is considered to remove the primary site of platelet destruction. The response rate is usually 60 to 70%. Again, however, the procedure is not without risk. About 10 to 20% of the individuals who undergo a splenectomy suffer a relapse and require further treatment. It is thought that the reticuloendothelial organs, particularly the liver, can become major sites for platelet destruction. If a splenectomy is unsuccessful and life-threatening thrombocytopenia persists, more aggressive immunosuppressive medications must be used. Because of potential major complications, these medications are reversed for individuals who are severely thrombocytopenic and refractive to other therapies. Thrombotic thrombocytopenic purpura, or TTP, is characterized by the concomitant occurrence of often severe thrombocytopenia and thrombotic microangiopathy, in which platelet aggregate and cause occlusion of the arterioles and capillaries within the microcirculation. Aggregation may lead to increased platelet consumption and organ ischemia, particularly that of the brain, heart, and kidneys. So here you're taking a look at a picture of thrombotic thrombocytopenic purpura. TTP is relatively uncommon, occurring only about 5 per 100 million individuals per year. The incidence is increasing, which appears to be an actual increase in the number of affected individuals, rather than the result of improved recognition. There are two forms of TTP, familial or acquired idiopathic. The familial form is more rare and is usually chronic, relapsing, as seen in children. The child experiences predictable, recurring episodes of approximately 3-week intervals that are responsive to treatment. Acquired TTP is more common and as well as more acute and severe. It occurs mostly in females in their 30s and is rarely observed in infants or older adults. Platelet aggregation and microthrombi formation are found throughout the entire vascular system, causing damage to multiple organs. Although the organs most susceptible to damage are the kidney, brain, heart, and other organs, often affected are the pancreas, spleen, and adrenal glands. The thrombi are primarily composed of platelets with minimal fibrin and red cells, differentiating them from thrombi secondary to intravascular coagulation. Most cases of TTP are related to the decrease or dysfunction of the plasma disintegrin and metalloproteinase, the ADAMTS13. This enzyme is responsible for the digesting of large precursor molecules of the Willebrand factor, which are produced by the endothelial cells into smaller molecules. The lack of ADAMTS13 enzyme activity alters the balance between bleeding and clotting. Decrease of defects in ADAMTS13 result in expression of large molecule weight von Willebrand on the endothelial cell surface and the formation of large aggregates of platelets. The aggregates may detach and form occlusions in smaller vessels. Most individuals with TTP have less than 5% of normal plasma ADAMTS13 levels. TTP also is commonly associated with an IgG autoantibody against ADAMTS13 that is able to neutralize the enzyme's activity and accelerate its clearance from the plasma. So your clinical manifestations. Clinical manifestations are the rare familial chronic relapsing TTP, observed often in children and usually recognized and successfully treated. The acquired acute idiopathic TTP is more common and more severe. Early diagnosis and treatment are important because the disease may be fatal within 90 days of onset. TTP is clinically related to and must be distinguished from other thrombotic microangiopathic conditions, including hemolytic uremic syndromes, malignant hypertension, preeclampsia, or the pregnancy-induced HELP syndrome. Hemolytic uremic syndrome shares many of the clinical characteristics of TTP. However, your hemolytic uremic syndrome often follows a hemorrhagic diarrheal illness. So its evaluation and treatment, therefore. Acute idiopathic TTP is characterized by the pathognomic pendet of symptoms. However, only 20 to 30% of people present with the classic pendet. These include extreme thrombocytopenia, intravascular hemolytic anemia, ischemic signs and symptoms, most often involved in the CNS, kidney failure, fever, and in about 33% of individuals um, is that fever. It is not mandatory that all 5 be present to begin treatment. A routine blood smear usually reveals fragmented red cells produced by the shear force when the red cells are in contact with the fiber mesh and clots that form in the vessels. As a result of tissue injury, serum levels of the lactase dehydrogenase may be very high and low-density lipoprotein levels may be elevated. Your tests for antibody on red cells are negative, excluding immune hemolytic anemia. Untreated acute TTP has a death rate of 90%, which can be reduced to 10 to 20% with prompt treatment. Plasma exchange with fresh frozen plasma replenishes functional ADAMTS13 and is the treatment of choice, achieving a response rate of 70 to 85%. Additionally, steroids are administered. In the absence of major organ damage, this approach may lead to a complete recovery with no long-term complications. The anti-CD20 monoclonal antibody rituximab has shown some activity in people who are refractory to plasma exchange. Caplazimumab, an anti-fosfatidide, has demonstrated platelet protective effects and increased tendency towards bleeding as compared to a placebo. Relapses do occur at a rate of 13 to 36%, and recurrences have reported, some as far out as 9 years. Individuals who do not respond to conventional treatment may be candidates for a splenectomy. However, post-op hemorrhage remains a dangerous complication. Your immunosuppressive therapy has been successful in some individuals. Thrombocytopenia. Thrombocytopenia is defined as, that's a lie, I'm not even reading thrombocytopenia. It's thrombocythemia. Thrombocythemia is defined as a platelet count greater than 450,000 of blood. Thrombocythemia may be primary or secondary and is usually asymptomatic until the count exceeds 1 million. The IV clot formation, hemorrhage, and other abnormalities can occur. So it's pathophysiology. Secondary thrombocythemia may occur after a splenectomy because platelets that normally would be stored in the spleen remain in the circulating blood. The increase in platelets may be gradual, with thrombocythemia not occurring for up to 3 weeks after a splenectomy. Reactive thrombocythemia may occur from infections and during some inflammatory conditions, such as rheumatoid arthritis and cancers. In these conditions, excessive productions of some cytokines may induce increased production of thrombopoietin in the liver, resulting in increased megakaryocyte proliferation. Reactive thrombocythemia also may occur during a variety of physiologic conditions, such as after exercise. Because of the relative self-resolving nature of secondary thrombocythemia, the remaining discussion will focus on a more severe primary form. The essential thrombocythemia is a chronic myeloproliferative disorder characterized by excessive platelet production resulting from a defect in bone marrow megakaryocyte progenitor cells. The overall incidence of essential thrombocytopenia, or ET, is 0.8 per 100,000 in the UK and 2.53 in the US and 0.59 in Denmark. It is more common in middle-aged individuals, with a majority of cases occurring between 50 and 60 years of age. There is no known gender preference. There also is a rare hereditary type of ET called familial essential thrombocytopenia that is inherited in an autosomal dominant pattern. Thrombocytopenia is secondary to increased plasma thrombopoietin levels, resulting from defects in the thrombopoietin receptor. The defective receptor cannot adequately bind and remove thrombopoietin from the blood. Thus, circulating levels remain high. Along with increased platelet levels, there may be a concomitant increase in the level of red cells, indicating a myeloproliferative disorder. However, the increase in red cells levels is not to the extent seen in Polycythemia Vera. The bone marrow of affected individuals with ET is characterized by hyperplasia and megakaryocytes. The platelets of affected individuals appear to have a normal survival time, compatible with a defect in production rather than an increase in platelet lifespan. Red blood cells in ET tend to aggregate and contribute to the blockage of flow in the microvasculature and altered interactions between platelets and vascular endothelium. Increased adherence of erythrocytes to the endothelium appears to result from a mutation in an erythrocyte genus kinase 2 gene that is responsible for the phosphorylation of the erythrocyte receptors for endothelial laminin. The frequency of JAK2 mutations in ET is about 30%. Increased platelet aggregation arises from several mutations that result in altered platelet membrane glycoproteins, particularly resulting in increased expression of GPIV and increased secretion of thromboxane. So its clinical manifestations, therefore, vary significantly among individuals. Those with ET are at risk for large vessel arterial or venous thrombosis, although the most common complication is microvascular thrombosis, leading to ischemia in the fingers, toes, or cerebrovascular regions. The primary presenting symptom of microvascular thrombosis are erythromegalalgia, headaches, and paresthesias. Erythromegalalgia is characterized by unilateral or bilateral, warm, congested red hands and feet with painful burning sensation, particularly in the forefoot, sole, or one or more of the toes. The lower extremities are affected more often and only one side may be involved. The pain is initiated by standing exercises or warmth and relieved by elevation or cooling. In extreme situations, acrocyanosis and gangrene may result. Arterial thrombosis is more common than venous thrombosis and may involve the coronary and renal arteries. The carotid, mesenteric, and subclavian arteries also may be affected. Myocardial ischemia and infarction have occurred without clear evidence of coronary artery disease. Your DVTs of the lower extremities and pulmonary emboli are the major sites for venous involvement. Common sites of intra-abdominal venous thrombosis are in the portal and hepatic circulation. People older than 60 years of age and those with a prior history of a thrombotic event have as much as 25% chance of developing a cerebral, cardiac, and peripheral artery thrombus. Conversion to acute leukemia is found in less than 10% of affected individuals. Microvascular thrombosis in the CNS is usually associated with headaches and dizziness with paresthesias, transient ischemic attacks, strokes, visual disturbances, and seizures also being reported. Major thrombotic events, not directly related to the platelet count, occur in about 20 to 30% of individuals with ET. Prior history of thrombotic events, advanced age, and duration of thrombocytosis are predictors of future thrombotic complications. Individuals older than the age of 60 are at greater risk. Although thrombosis is the most common symptom, hemorrhage can also occur. Sites for bleeding include the GI tract, skin, mucous membranes, urinary tract, gums, tooth sockets, joints, eyes, and brain. Your GI bleeding may be mistaken for a duodenal ulcer. Hemorrhage is not severe and generally occurs in the presence of very high platelet count, occasionally requiring transfusions. It is important to recognize that bleeding and clotting may exist simultaneously, and individuals may not necessarily be bleeders or clotters. So it's evaluation and treatment, therefore. Initial diagnosis is not difficult. As many as two-thirds of affected individuals are diagnosed from a routine CBC. Secondary thrombocytosis may present as a moderate rise in the platelet count that resolves with treatment or resolution of the underlying condition. The World Health Organization criteria for the diagnosis of ET requires that the following four conditions be met: sustained platelet count of at least 450 times 10 to the ninth, a bone marrow biopsy showing proliferation of enlarged mature megakaryocytes, and no increase in granulocytes or erythrocyte precursors. The person does not meet the criteria of Polycythemia Vera, myelofibrosis, chronic myeloid leukemia, and other myelodysplastic syndromes. And lastly, the presence of a JAK2, or another clonal marker, or evidence of reactive thrombocytosis. After diagnosis, these individuals may recall events related to thrombosis or hemorrhage. Manifestations of AT may be mistaken for CML. Therefore, differentiation of the two is important because treatment varies significantly. Identification of the Philadelphia chromosome is recommended in all cases of ET. Treatment of ET is directed toward preventing thrombosis or hemorrhage. The reduction of platelet count remains a significant treatment issue. Historically, treatment of ET relied on the use of alkylating agents and radiophosphorus to suppress platelet production. Hydroxyurea, a non-alkylating myelosuppressive agent, has been the drug of choice to suppress platelet production. However, long-term use may cause progression to other myelodysplastic disorders, particularly AML or myelofibrosis. Conversion to myelofibrosis occurs approximately 8% of time, and conversion to AML occurs about 3.5% of the time when treated with hydroxyurea as a single cytotoxic agent, but increases to 14% when more than one cytotoxic agent is used. Interferon also may be used as a response rate of 80%. Interferon may not work for everyone because it has many side effects, and 20% of individuals may be intolerant. Anagrelide is now considered to be the drug of choice. Anagrelide specifically interferes with platelet maturation rather than production, thus not affecting erythropoiesis or leukopoiesis. Aspirin also is used in the treatment of ET. However, its action is not to reduce the platelet count, but to prevent adherence of platelets to each other and prevent thrombus formation. Early studies with aspirin found hemorrhage to be a major contraindication for its use. However, in lower doses, it effectively alleviates erythromelalgia and transient neurologic manifestations. Vitamin K antagonists are used as a secondary prevention of thrombosis in those with ET. Prognosis and survival of individuals with ET have been somewhat difficult to establish. ET is not necessarily considered life-threatening. However, in people who are older than 60 and have a history of previous incidents of thrombosis, complications are more common and have a higher risk of mortality, leading us to the alterations of the platelet function. Qualitative alterations in platelet function occur in an increased bleeding time in the presence of normal platelet count. Associated clinical manifestations include spontaneous petechiae and purpura, and bleeding from the GI tract, genitourinary tract, pulmonary mucosa, and gums. Congenital alterations in platelet function are quite rare and may be categorized into several types of disorders, including the platelet vessel wall adhesion, platelet-platelet interaction, platelet granules and secretion, the arachidonic acid pathways, and the membrane phospholipid regulation. Disorders of platelet vascular wall adhesion result from aberrations of the platelet membrane glycoprotein, that GPIB 9 and 5, anomalies of the collagen receptor, GPBI, or deficiencies of the von Willebrand factor. GPIB protein is the most commonly mutated protein in individuals in the Bernard-Soulier syndrome. Lack of these proteins prevent platelets from adhering to collagen, resulting in impaired homeostasis and clinical hemorrhage. Disorders in the platelet-platelet interaction result in failure of platelets to aggregate in response to adenosine diphosphate, collagen, epinephrine, or thrombin because of the deficiency in the glycoprotein that acts as a receptor for fibrinogen, von Willebrand factor, and fibronectin. Lack of this glycoprotein result in a failure to build fibrinogen bridges between platelets. Defects also can occur in platelet receptors for platelet activators. These include mutations in the receptors for the thromboxane or ADP. Disorders of platelet granules and the secretion and disorders of arachidonic pathways are characterized by initial normal platelet aggregation with collagen or ADP. However, subsequent processes fail, specifically secretion of prostaglandins and the release of granules, defective alpha granule number, or release. Results from mutations in several aspects of granule function, including the biosynthesis or loading of proteins normally found in these granules. Defects in the dense granules include the Hermansky-Pudlak syndrome, Chidiac-Higashi syndrome, and delta storage pool disease. These usually result from mutations in proteins involved in the formation of dense granules or their movement to the plasma membrane. Defects in the thromboxane pathway prevent the release of this mediator. Externalization of plasma membrane phosphatidylserine is necessary for effective platelet function. In Scott syndrome, the enzyme responsible for PS efflux is defective. Thus, platelets are unable to support the activation of factor X and prothrombin. The reverse of Scott syndrome is Storm-Wilkins syndrome, in which platelets constitutively externalize PS. Acquired disorders of platelet function are more common than the congenital disorders and may be categorized into three principal causes: your drug effects, systemic inflammatory conditions, and hematologic conditions. Multiple drugs are known to affect platelet function in several ways: the inhibition of platelet membrane receptors, inhibition of prostaglandin pathways, and the inhibition of the phosphodiesterase activity. Aspirin is the most commonly used drug that affects platelets and the only drug specifically used for its platelet effects. It irreversibly inhibits cyclooxygenase function for several days after administration. Non-steroidal anti-inflammatory drugs also affect the cyclooxygenase, although in a reversible fashion. Systemic disorders that affect platelet function are chronic renal disease, liver disease, cardiopulmonary bypass surgery, severe deficiencies of iron or folate, and the presence of antiplatelet antibodies associated with autoimmune disorders. Hematologic disorders that cause platelet dysfunction are chronic myeloproliferative disorders, multiple myeloma, leukemias, myelodysplastic syndromes, and the dysproteinemias, leading us to disorders of the coagulation. Disorders of coagulation usually are caused by defects or deficiencies of one or more of the clotting factors. Qualitative or quantitative abnormalities of clotting factors interfere with or prevent the enzymatic reaction that transforms circulating clotting proteins into a stable fibrin clot. Some clotting factor defects are inherited and usually involve a single factor such as hemophilias and von Willebrand disease, caused by deficiencies of specific clotting factors. Other coagulation defects are acquired and tend to result from deficient synthesis of clotting factors by the liver. Causes include liver disease and dietary deficiency of vitamin K. Other coagulation disorders are attributed to the pathologic condition that triggers coagulation inappropriately. For example, a cardiovascular abnormality that alters normal blood flow by accelerating, decelerating, or obstructing. It can result in spontaneous coagulation within the vessel. Coagulation is also stimulated by the presence of tissue factor, which is released by damaged or dead tissue. Vasculitis or inflammation of the blood vessel, as well as vessel damage, activates platelets, which in turn activates the coagulation cascade. In extensive or prolonged vasculitis, blood clot formation can suppress mechanisms that normally control clot formation and breakdown, leading to clogging of the vessels. In each of these acquired conditions, normal hemostatic function proves detrimental to the body by consuming coagulation factors excessively or by overwhelming the normal control of clot formation and its breakdown. Impaired homeostasis. Impaired homeostasis, or the inability to promote coagulation and the development of the stable fibrin clot, is commonly associated with liver disorders, resulting either from a lack of vitamin K or from specific diseases of the liver. So, that brings us to that vitamin K deficiency. Vitamin K, a fat-soluble vitamin, is necessary for the synthesis and regulation of prothrombin procoagulant factors, so 7, 9, and 10, and anticoagulant regulators, your protein C and S, within the liver. Vitamin K is found in our green leafy vegetables, which is its primary dietary source. Vitamin K also is synthesized by the intestinal flora, but its contribution to the overall supply of vitamin K is uncertain. The most common cause of a vitamin K deficiency is the parental nutrition in combination with broad-spectrum antibiotics that destroy normal gut flora. Rarely is a deficiency caused by a lack of dietary intake. However, bulimia can suppress vitamin K dependent activity. Clinical manifestations of vitamin K deficiency are caused by a reduction of vitamin K dependent proteins. The severity of manifestations is related to the degree of deficiency and ranges from lab abnormalities to significant hemorrhage. Parenteral administration of vitamin K is the treatment of choice and usually results in the correction of the deficiency. Improvement clotting tests is usually noted within 8 to 12 hours. Fresh frozen plasma may be administered but usually is reserved for individuals with life-threatening hemorrhages or who require emergency surgery. Liver disease. Individuals who have liver disease or major liver surgery present with a broad range of homeostasis derangements that may be characterized by defects in the clotting or fibrinolytic symptoms or in platelet function. The hepatic parenchymal cells produce most of the factor involved in homeostasis. Thus, damage to the liver frequently results in diminished production of factor involved in the clotting, usually in proportion to the degree of hepatic parenchymal cell damage. For instance, factor VII is most sensitive to liver damage because of its rapid turnover. Factor IX levels are less affected and do not decline until liver destruction is well advanced. The liver is also a major site for production of plasminogen and alpha antiplasmin of the fibrinolytic system, as well as thrombopoietin and the metalloprotease ADAMTS13. Diminished levels of thrombopoietin may lead to thrombocytopenia from decreased platelet production. Decreased production of ADAMTS13 results in increased levels of large precursor molecules of von Willebrand factor, which leads to the formation of large aggregates of platelets. In conditions of severe liver disease, circulating levels of most clotting factors are significantly depressed. Concurrently, production of clotting system regulators and of fibrinogen is diminished. The fibrinolytic system is commonly active because of decreased levels of plasmin inhibitors and unaffected levels of fibrinolytic activators. The affected individuals also are thrombocytopenic because of the diminished production of the thrombopoietin and ADAMTS13, as well as increased platelet sequestration in the spleen, which is frequently enlarged in cirrhosis and is associated with portal hypertension. Thus, individuals with cirrhosis may appear to have a condition similar to DIC. Treatment of homeostatic alterations in liver disease must be comprehensive to cover all aspects related to platelet clotting and fibrinolytic dysfunction. Fresh frozen plasma administration is the treatment of choice, but not all individuals tolerate the volume needed to adequately replace all deficient factors. Alternative modalities include the addition of exchange transfusion and platelet concentration to plasma administration. Consumptive thrombohemorrhagic disorders, therefore, are the heterogeneous group of conditions that demonstrate the entire range of hemorrhagic and thrombotic pathologic conditions. Symptoms range from subtle to devastating and generally are considered to be the intermediary disease process that complicate many primary disease states. These disorders also are characterized by the confusion and controversy regarding diagnosis, treatment, and management. No one definition can cover all possible varieties of these disorders. However, disseminating intravascular coagulation is the most common term used in the clinical setting to describe a pathologic condition associated with hemorrhage and thrombosis. So, DIC, or disseminating intravascular coagulation, is an acquired clinical syndrome characterized by the widespread activation of coagulation resulting in the formation of fibroclots in medium and small vessels throughout the body. Disseminating clotting may lead to a blockade of blood flow to organs, resulting in multiple organ failure. The magnitude of clotting may result in consumption of platelets and clotting factor, leading to severe bleeding. Subcommittees on DIC of the International Society on Thrombosis and Homeostasis define DIC as an acquired syndrome, characterized by the intravascular activation of the coagulation with loss of localization arising from different causes. It can originate from and cause damage to the microvasculature, which is sufficiently severe, can produce organ dysfunction. The ISTH has contributed to the defining better criteria and clinical management strategies. The clinical course of DIC largely is determined by the intensity of the stimulus, host response, and comorbidities, and it ranges from an acute, severe, life-threatening process that is characterized by massive hemorrhage and thrombosis to a chronic low-grade condition. The chronic condition is characterized by subacute hemorrhage and diffuse microcirculatory thrombosis. DIC may be localized to one specific organ or generalized involving multiple organs. Because of the complexity and wide variations in manifestations of DIC, diagnosis has been challenging. Diagnostic criteria have been established and include a systemic thrombohemorrhagic disorder with a lab evidence of a clotting activation, fibrinolytic activation, coagulation inhibitor consumption, and biochemical evidence of end organ damage or failure. DIC is secondary to a wide variety of well-defined clinical conditions, specifically those capable of activating the clotting cascade. These include arterial hypotension, frequently accompanying shock, hypoxemia, academia, and stasis of the capillary blood flow. So here in this box, you see the clinical conditions associated with DIC. So let's get spotted, pause, and review. Sepsis is the most common condition associated with DIC. Your gram-negative microorganisms, fungi, protozoa, and viruses are capable of precipitating DIC by causing damage to the vascular endothelium. Gram-negative endotoxins are the primary cause of endothelial damage. DIC may occur in up to 50% of individuals with gram-negative sepsis. DIC occurs in approximately 10 to 20% of individuals with metastatic cancer and acute leukemias. Direct tissue damage also results in the release of the tissue factor by the endothelium. Severe trauma, especially to the brain, can induce DIC. DIC occurs in about two-thirds of individuals with a systemic inflammatory response to trauma. Some complications of pregnancy also are associated with DIC. Incidence ranges from 50% for women with placental abruptions to less than 10% for severe preeclampsia. Other causes of DIC have been identified, most notably blood transfusion. Transfused blood dilutes the clotting factor as well as circulating naturally occurring antithrombins. In hemolytic transfusion reactions, the endothelium is damaged by the complement-mediated reaction. So it's pathophysiology. The coagulation system is designed to function at local areas of vascular damage, resulting in cessation of bleeding and activation of repair to the vessel. DIC results from abnormally widespread and ongoing activation of clotting. A variety of conditions are associated with DIC. Again, see the prior box. The common pathway for DIC appears to be excessive and widespread throughout exposure of TF. This may occur by several mechanisms. Widespread damage to the vascular endothelium result in exposure of subendothelial TF. Several types of cells, either produced after stimulation by cytokines or occurring constitutively, express TF on their surface. Normally, endothelial cells and monocytes do not express surface TF unless stimulated by inflammatory cytokines. Many tumors express surface TF or produce cytokines that stimulate TF expression by the endothelium or monocytes or both. The cytokines are abundantly produced during many of the conditions listed in that box. Endotoxin, in particular, triggers the release of multiple cytokines that play a significant role in the development and maintenance of DIC. Your pro-inflammatory cytokines and platelet activating factors are responsible for the clinical signs and symptoms associated with sepsis. They also contribute to the development of DIC by activating endothelial cells, causing release of TF and von Willebrand factor, increasing plasminogen activator inhibitor 1 synthesis and tissue factor activity, and decreasing thrombomodulin expression, thereby promoting development of thrombi. TF also may be released directly into the bloodstream from the circulating white blood cells. So here you see different pathways of disseminating intravascular coagulation. It's pathophysiology. So TF clotting factor 7, which leads to the conversion of prothrombin to thrombin and formation of fibrin clots. This pathway appears to be the primary route by which DIC is initiated. Inhibition of TF or factor 7A completely prevents the generation of thrombi by gram-negative bacterial endotoxin in animal models of DIC. Not only is the clotting system extensively activated in DIC, but levels of the predominant natural anticoagulant are also greatly diminished. During DIC, the activation of clotting prolonged by the increased rate of consumption of clotting factors and platelets because of the persistent thrombin production as well as the decreased synthesis of the natural anticoagulant and protein S, and by the cytokine-mediated decreased expression of thrombomodulin on the endothelial cell surface. Hepatic dysfunction and sepsis results in decreased antithrombin synthesis and extravascular leakage of this protease inhibitor because of the capillary leakage. Additionally, antithrombin is degraded by elastase release by activated neutrophils, and clotting is initiated concurrently with loss of regulation of the extent of thrombosis. Thus, the amount of thrombin produced during DIC exceeds the ability of the body's naturally occurring anticoagulants to regulate it. The rate of fibrinolysis is also diminished in DIC. The primary component of fibrinolysis is plasmin, which exists in the circulation as an inactive precursor, plasminogen. Plasminogen is activated to plasmin that digests fibrin clots, thus controlling the extent of fibrin deposition in the vessels. During DIC, the activity of plasmin is diminished by increased production of its natural inhibitor, the PAI1. Although some fibrinolytic activity remains, the level is inadequate to control the systemic deposition of fibrin. The slow breakdown of fibrin by plasmin produces fibrin degradation products that are released in the blood. These are potent anticoagulants that are normally removed from blood by fibrinonectin and macrophages. FDPs, along with thrombin, induce further cytokine release from monocytes, contributing to the endothelial damage and TF release. During DIC, the presence of fibrin degradation products is prolonged, probably because of the diminished production of the fibronectin. Fibronectin is a glycoprotein with adhesive properties that mediate removal of particulate matter. Low levels of fibronectin suggest a poor prognosis. Although thrombosis is generalized and widespread, individuals with DIC are paradoxically at risk for hemorrhage. Hemorrhage is secondary to the abnormally high consumption of clotting factor and platelets, as well as the anticoagulant properties of FDPs, which interfere with polymerization of fibrin monomers. Both thrombin and FDPs have a high affinity for platelets and cause platelet activation and aggregation, an event that occurs early in the development of DIC, and that facilitates microcirculatory coagulation and obstruction in the initial phase. However, platelet consumption exceeds production, resulting in a thrombocytopenia that increases bleeding. Activation of clotting also leads to the activation of other inflammatory pathways, including the kallikrein-kinin and complement systems. Factor XIIa, generated in DIC, converts prekallikrein to kallikrein, ultimately resulting in conversion to circulating kinins. Activation of these systems contribute to increased vascular permeability. Hypotension and shock, activated complement components, also induce platelet destruction, further contributing initially to the thrombosis and later to the thrombocytopenia. The deposition of fibrin clots in the circulation interferes with blood flow, causing widespread organ hypoperfusion. This condition may lead to ischemia, infarction, and necrosis, further potentiating and complicating the existing DIC process by causing additional release of TF and eventual organ failure. In addition to initiating of clotting by TF, DIC may be precipitated by direct proteolytic activation of factor X. This has been described as thrombin mimicry and is a result of activated factor X directly converting fibrinogen to fibrin. The proteases that activate factor X may come from snake venom, some tumor cells, or the pancreas and liver, where they are released during episodes of pancreatitis and various stages of liver disease. Direct proteolytic activity appears to be independent of any type of damage to the endothelium or tissue. Vascular obstruction results from circulatory deposition of thrombin and clot formation that impedes blood flow, causing widespread organ hypoperfusion that can lead to tissue ischemia, infarction, and necrosis. The resulting tissue damage further potentiates to complicates the existing DIC process. Because organ perfusion is drastically impaired, manifestations of multisystem organ dysfunction and failure ultimately result. Multisystem organ dysfunction and failure are again discussed in Chapter 49. Whatever initiates the process of DIC, the cycle of thrombosis and hemorrhage persists under the underlying cause of DIC, and once it's removed or appropriate therapeutic interventions are used. So, clinical manifestations. Clinical signs and symptoms of DIC present a wide spectrum of possibilities, depending on the underlying disease process that initiates DIC and whether the DIC is acute or chronic. Most symptoms are the result of either hemorrhage or thrombosis. Acute DIC presents with rapid development of hemorrhaging, such as oozing from venopuncture sites, arterial lines, and surgical wounds, or the development of ecchymotic lesions and hematomas. Other sites of bleeding include the eyes, the nose, and the gums. Most individuals with DIC demonstrate bleeding at 3 or more unrelated sites, and any combination may be observed. Shock of variable intensity out of proportion to the amount of apparent blood loss also may be observed. Hemorrhaging, also closed compartments of the body, also can occur and may precede the development of shock. So here you see the clinical manifestations of DIC in various areas. If I'm ever going too quickly, please go ahead and hit pause. DIC has been conceptualized as a systemic hemorrhagic disorder because bleeding, sometimes very extensive, is usually the initial observation. Symptoms of thrombosis are not always as evident, even though it is often the first pathologic alteration to occur and ultimately determines the degree of morbidity and risk for death. A large amount of microvascular and macrovascular occlusion may occur. That is not clinically obvious. Several organ systems are susceptible to the microvascular thrombosis that affect the function. These include the cardiovascular, pulmonary, central nervous, renal, and hepatic system. Quick and accurate clinical diagnosis is critical to preventing further progression of DIC that may lead to multisystem organ dysfunction and failure. Indicators or multisystem failure include changes in level of consciousness, behavior, and mentation, confusion, seizure activity, oliguria, hematuria, hypoxia, hypertension, hemoptysis, chest pain, and tachycardia. Symmetrical cyanosis of the fingers and toes, and in some instances, of the nose and breast may be present. Symmetrical parts are often affected and are indicative of microvascular thrombosis. This may progress to infarction and gangrene, requiring amputation. Jaundice also may be present and is believed to result from red blood cell destruction rather than hepatic dysfunction. Individuals with chronic or low-grade DIC do not present with overt manifestations of hemorrhaging and thrombosis, but instead have a subacute bleeding and diffuse thrombosis, and are described as having a compensated DIC or non-overt DIC. The major characteristic of this state is the increased turnover and decreased survival time of the components of homeostasis. Platelets and clotting factor occasionally diffuse or localized thrombosis develops because this is infrequent. So its evaluation and treatment, therefore. No single lab test can be used to effectively diagnose DIC. Diagnosis is based primarily on the clinical symptoms and confirmation by the combination of lab tests. The individual must present with a combination of lab tests. The individual must present with clinical condition that is known to be associated with DIC. The most common used combination of lab tests usually confirms thrombocytopenia or rapid decreasing platelet count on repeated testing, prolongation of clotting times, the presence of fibrin degradation products, and decreased levels of coagulation inhibitors. The relationship between the criteria is summarized in the following box. Your platelet count must be less than 100,000 or a progressive decrease in platelet count is very sensitive for DIC. Although not greatly specific, these changes usually indicate consumption of platelets. So here you see the lab diagnostics. So again, a good spot to hit pause so you can review. The standard coagulation test. Your PT, PTT, and INR also have a high degree of sensitivity, but they are not highly specific for DIC. As a result of consumption of circulating clotting factor, these tests are usually abnormal, ranging from shortened to prolonged times. However, conditions other than DIC may prolong clotting times. Assays of specific clotting factors do not contribute to meaningful diagnostic information. Detection of various fibrin degradation products is more specific. For DIC, of these tests, the detection of D-dimers is most widely used, reliable, and a specific test. A D-dimer is a molecule produced by the plasma degradation of cross-linked fibrin in clots. D-dimers is the blood that can be quantified using enzyme-linked immunosorbent assay tests that include commercially available and highly specific monoclonal antibodies against D-dimer. Agglutination tests for other fibrin degradation products are available. Levels of fibrin degradation products in general are elevated in the plasma in 95% to 100% of cases. However, concentrations of FDPs are less specific and only document the presence of plasmin and its action of fibrin, whereas detection of D-dimers measures a specific DIC-related product. ELISA for markers of thrombin activation are sometimes used. Normal conversion of PT to thrombin produces an active prothrombin fragment of 1.2. This fragment is released from the prothrombin molecule, generating an intermediate factor, prethrombin 2. Once generated, prethrombin 2 can either split to produce thrombin, which can then proteolyze fibrinogen and thus liberate fibrinopeptide A, or it can combine with its major antagonists and form a stable inactive enzyme inhibitor complex, the thrombin-antithrombin complex. Assays of these factors are now generally available to quantify their blood levels, providing evidence of excessive factor Xa and thrombin generation. Levels of coagulation inhibitors can be measured by assays that rely on the function by ELISAs that quantify the amount of the specific inhibitor. Your AT3 levels can provide key information for diagnosing and monitoring therapy for DIC. Initial levels of functional AT3 are low in DIC because thrombin is a reversible complex with activated clotting factor at AT3. Treatment of DIC is directed towards eliminating the underlying pathology, controlling the ongoing thrombosis, and maintaining organ function. Elimination of the underlying pathology is the initial intervention in the treatment phase in order to eliminate the trigger for activation of clotting. Once the stimulus is gone, production of coagulation factor in the liver leads to restoration of normal plasma levels within 24 to 48 hours. Control of thrombosis is more difficult to attain. Heparin has been used for this. However, its use is controversial because the mechanism of action is binding to and activating AT3, which is deficient in many types of DIC. Current heparin is indicated only in certain situations related to DIC. For instance, heparin seems to be effective in DIC caused by the retained dead fetus or associated with acute promyelocytic leukemia. Organ function is compromised by microthrombi, and there is a risk of losing an extremity because of vascular occlusion. Thus, heparin has also been indicated in these conditions. Heparin's usefulness, however, for DIC is precipitated by septic shock, has not been established, and so is contraindicated in that instance. Heparin is also contraindicated when there is evidence of post-op bleeding, peptic ulcers, or CNS bleeding. Replacement therapy is gaining recognition as an effective treatment modality. Components used in replacement therapy include platelets, fresh frozen plasma, and cryoprecipitates. Platelets are given for thrombocytopenia, plasma to provide volume and replaces clotting factor, and cryoprecipitates replaces the fibrinogen. Their use is not without controversy. However, because of the possible risk of adding components that will increase the rate of thrombosis, clinical judgment is the key factor in determining whether replacement is to be used as a treatment modality. Several clinical trials are evaluating replacement of anticoagulants. Studies assess that the use of anticoagulants are presented in the review by Gando and colleagues. Antifibrinolytic drugs also are used in the treatment, but are limited to instances of life-threatening bleeding that have not been controlled by blood component replacement therapy. Maintenance of organ function is achieved by fluid replacement to sustain adequate circulating blood volume and to maintain optimal tissue and organ perfusion. Fluid may be required to restore blood pressure, cardiac output, and urine output to normal parameters. Your thromboembolic disease. Certain conditions within the blood vessels predispose an individual to develop clots spontaneously. A stationary clot attached to the vessel wall is called a thrombus. A thrombus is composed of fibrin and blood cells and can develop in either the arterial or venous system. Arterial thrombi form under the conditions of high blood flow and are composed mostly of platelet aggregates held together by fibrin strands. Venous thrombi form in the conditions of low flow and are composed mostly of red cells with larger amounts of fibrin and a few platelets. So here's a picture of a thrombus. A thrombus may eventually grow large enough to reduce or obstruct blood flow to tissues or organs, such as the heart, brain, or lungs, depriving them of essential nutrients critical for survival. A thrombus also has the potential of detaching from the vessel wall and circulating within the bloodstream, which is considered an embolus. The embolus may become lodged in smaller blood vessels, blocking blood flow into the local tissue or organ and leading to ischemia. The potential for episodes of thromboembolism to become life-threatening depends on the site of vessel occlusion. Therapy consists of removal of breakdown of the clot and provision of supportive measures. Anticoagulant therapy is effective in treating or preventing venous thrombosis. It is not as useful in treating or preventing arterial thrombosis. Parenteral heparin is the major anticoagulant used to treat thromboembolism. Oral coumarin drugs also are widely used, particularly for individuals not hospitalized. More aggressive therapy may be indicated for such conditions as pulmonary emboli, coronary thrombosis, and thrombophlebitis. Streptokinase and urokinase activates the fibrinolytic system and are administered to accelerate the lysis of known thrombi. Thrombolytic therapy has limited uses and is prescribed with a high degree of caution because it can cause hemorrhagic complications. The risk for developing spontaneous thrombi is related to several factors. Refer to the Virchow triad: injury to the blood vessel endothelium, abnormality of blood flow, and the hypercoagulability of the blood. Vascular endothelial injury can result from atherosclerosis. Atherosclerosis initiates platelet adhesion and aggregation, promoting the development of atherosclerotic plaque that enlarges, causing further damage and occlusion. Other causes of vessel endothelial injury may be related to the hemodynamic alterations associated with hypertension and turbulent blood flow. Injury also is caused by radiation injury, exogenous chemical agents, endogenous agents, bacterial toxins or endotoxins, or immunologic mechanisms. Whatever the precipitating cause of endothelial injury, it is a potent thrombotic agent. Turbulent blood flow in the arteries and stasis of blood flow in the vein are at-risk conditions for thrombus formation. In areas of turbulence, platelets and endothelial cells may be activated, leading to thrombosis. In states of stasis, platelets may remain in contact with the endothelium for prolonged times, and clotting factors that would normally be diluted with fresh flowing blood are not diluted and may become activated. The most common clinical condition that predisposes to venous stasis and subsequent thromboembolic phenomena are major surgery, acute myocardial infarctions, congestive heart failure, limb paralysis, spinal injury, malignancy, advanced age, the postpartum period, and bed rest longer than 1 week. Turbulence and stasis occur with ulcerated atherosclerotic plaques, hyperviscosity, and conditions with deformed red cells. Hypercoagulability and thrombocytopenia is the condition in which an individual is at risk for thrombosis. Hypercoagulability is differentiated according to whether it results from primary or secondary causes. Primary causes include defects in proteins involved in homeostasis. Secondary causes include a variety of clinical disorders and conditions. It is not well understood why there is not a greater incidence of thrombosis formation in a hypercoagulable state associated with various diseases. So here is different hypercoagulable states, whether it's a primary or secondary. So, hereditary thrombophilias. A large number of inherited conditions have been identified that increase the risk of developing a thrombosis. Most are autosomal dominant. Thus, individuals who are homozygous for the mutation are at greater risk for thrombosis. These include mutations in coagulation proteins, fibrinolytic proteins, platelet receptors, and other factors. The mutations most strongly linked as risk factors for venous thrombosis are for arterial thrombosis leading to coronary artery disease or stroke, including those that affect prothrombin and factor V of the coagulation system. Other inherited thrombophilias are reviewed in the following box. Factor V. The Leiden result from a single nucleotide mutation of guanine to adenine at nucleotide 1691. Activated factor V is usually inactivated by protein C, but the single mutation results in a change in amino acid 506 from arginine to glutamine. The change alters the site where protein C would cleave factor V'a and confers partial resistance, resulting in a prolonged higher level of factor V'a and prolongation of clot formation. Although this mutation increases the risk for thrombosis, Most individuals with factor V Leiden do not have clinical relevant thrombotic events. It is most common hereditary thrombophilia and is found in about 30% of individuals presenting with a DVT or PE. It is primarily observed in individuals of European ancestry and in about 5% of white Americans. The second most common inherited form of thrombophilia is the mutation in the F2 gene, the mutation that causes prothrombin thrombophilia results in an overactive F2 gene that causes too much prothrombin to be produced. An increase in the prothrombin level leads to more thrombin, which promotes the formation of blood clots. Other factors that increase the risk of blood clot include increasing age, obesity, trauma, surgery, smoking, and the use of oral contraceptives or hormone replacement therapy, as well as pregnancy. Other mutations in genes involved in blood clotting also can influence the risk. The acquired hypercoagulability. The acquired thrombophilias are often multifactorial. An example of an acquired hypercoagulable state is antiphospholipid syndrome, an autoimmune syndrome characterized by autoantibodies against plasma membranes. The phospholipids and phospholipid-binding proteins. As with most autoimmune diseases, the predominant affected individual is female and of reproductive age. Those with APS are at risk for arterial and venous thrombosis and a variety of obstetric complications, including the loss in pregnancy, and preeclampsia and eclampsia. In severe cases, the person may die from recurrent major thrombus formation. The pathophysiology is related to the autoantibodies directed reacting with platelets or endothelial cells, or the placental surface. The predominant diagnostic test measure prolongation of laboratory blood coagulation test related to the antibody inhibitor and specific ELISA for antibodies against phospholipids or proteins that bind to phospholipids. Highly effective therapy include your unfractionated low molecular weight heparin and low dose aspirin are available to prevent obstetric complications. So here in this box you see the clinical conditions associated with a high risk for thrombosis and thromboemboli. And then you see a picture of arterial thrombosis. And that concludes our chapter. I thank you as always for listening, and I'll see you at the next chapter. Until then, thank you and goodbye.